Hello dear students, a very good afternoon to all of you. Please confirm if I am audible and if my screen is visible. Good afternoon Zubair, Ashik, Israr, Medical FMGE. Good afternoon everyone. Can someone give a quick confirmation if I am audible and if my screen is visible? Thank you Preeti. Right. So welcome to this last resort revision session for your upcoming exams. So now with less than 1 month left for your exams, it will be a quick revision session and I would want it to be an interactive one. I want maximum participation from all of you because if we are involved in active learning and active revising, obviously we can recall the facts better, right? So I've tried to cover very important topics for your upcoming exams, and this time I've done it in the form of 3 separate sections. So we'll be first discussing the important topics from neonatology, then from general pediatrics, and finally from systemic pediatrics. And don't worry, you'll get a PDF, annotated PDF at the end of the session. So please focus on answering the questions, on revising your concepts, right? Okay. So, of course, this is targeted for the upcoming FMGE exams, but yes, anyone who is preparing for, any exam, MCQ based exam after your MBBS, that is FMG, NEET PG and even INI-CET, definitely everyone is going to benefit from it. Okay, so let's start. So, we will be starting with important topics from neonatology. Okay, so of course, we'll do it in a question answer fashion so that it can be interactive and I can see that you are answering properly, how are you answering, and the problems that you're facing while answering the questions we can address simultaneously. So, identify this condition, okay. So, you can see a condition here, you can see a picture has been given to you. So, what you have to do is identify this condition in an infant. What do you mean by infant? A baby born at, so a baby whose age is less than 1 year, okay. So, an infant with this swelling of head, can you appreciate this swelling of head? It is a unilateral kind of swelling, okay, on one side, okay. So, if you are looking from the head end, this is the left side and this is the right side, right. So, so you have this unilateral swelling present since birth and it is even seen at 2 weeks of life. The baby is otherwise fine but has neonatal jaundice. So, I can see most of you answering correctly, yes. So, what is it? It is cephalhematoma, right? Why not Caput succedaneum? So, we will see the important differences between Caput succedaneum and cephalhematoma and then we will come back to the other options, okay. So, let us see the important differences because you can get questions, true and false questions about cephalhematoma or Caput succedaneum and we need to identify and answer them. So, cephalhematoma as the name itself is telling you it is a hematoma. What is hematoma? So, it is a collection of blood where, so it is subperiosteal hemorrhage involving the cranial bones. So, it is nothing but subperiosteal hemorrhage involving cranial bones, okay. While what is Caput succedaneum? Caput succedaneum is nothing to do with the cranial bones or hemorrhage, it is basically edema in the layers of scalp. So, it is a soft tissue swelling, edema in the layers of scalp, right. Cephalhematoma, because we know each bone has got its own periosteum. So, this is collection of blood between the bone and periosteum. So, it will remain confined to any one bone, right, or multiple bones, but there will be separate swellings. So, in between we have this suture here, right, we have this suture in between. So, what happens? So, because the sagittal suture is there, we know this cephalhematoma does not cross sutures. So, it is not going to cross midline usually. So, cephalhematoma, the swelling does not cross sutures, okay. But Caput succedaneum can cross sutures, right. Cephalhematoma, because it is a collection of blood, it takes time to appear also, disappear also. So, cephalhematoma appears completely in 24 to 48 hours and disappears in 5 to 7 weeks. And because it is a collection of blood, it predisposes the baby to neonatal jaundice. Why? Because blood breaks down to hemoglobin, heme, biliverdin, bilirubin. Remember the physiology pathway? So neonatal jaundice, more chances in cephalhematoma. While Caput succedaneum, what did we say? It can cross sutures, it appears immediately. So immediately after birth, it is present in maximum size. Okay, immediately after birth. And when does it disappear? So it disappears in 48 to 72 hours and it does not predispose to jaundice. So coming back to our case scenario, so this baby has got this swelling even at 2 weeks of life. So it cannot be Caput succedaneum. Caput succedaneum is going to subside by 48 to 72 hours. And this baby has neonatal jaundice also. We know cephalhematoma predisposes to neonatal jaundice, Caput does not. And the baby is otherwise fine. So that is why it is not subgaleal bleed. So subgaleal bleed is a more severe condition. So here the bleeding happens below the galea aponeurotica, right? So the muscle sheet that is there, below that the bleeding may occur, and because it is a big space, a lot of bleeding can happen in subgaleal hemorrhage and the baby can be pale, in shock, hemodynamic instability can be there. So here the baby is otherwise fine, so it is not subgaleal bleed. And encephalocele, we know what is encephalocele, it is a neural tube defect where what happens, there is herniation of the meninges and a part of the brain can also come out. So herniation through the meninges, so encephalocele will be a swelling like this if it is present, mainly in the occipital region usually it is seen. So all these are not the correct answers, so the best answer of course here is cephalhematoma, right? Moving ahead, yes. So which of the following, so some people are telling me to use Hindi as well, so if everyone is comfortable in between I can do that. Which of the following is considered harmful to a newborn baby in the immediate postnatal period, right? So immediate postnatal period, we know what should the baby get. So before answering so I can see most of you answering correctly, but before coming to the options, let us discuss what should be done for each baby after birth. Each baby after birth should receive what is called essential newborn care. And what does this essential newborn care include? It includes immediate care at birth, which includes what? It includes neonatal resuscitation. So whatever resuscitation is required as per the neonatal resuscitation guidelines that we will be discussing shortly, neonatal resuscitation should be done. Delayed cord clamping, if the baby is stable, delayed cord clamping should be done, right? Okay, and you have to keep observing the baby also to see if the baby is developing any problems or not, okay? So immediate care at birth should be given. Thermal care. So if the baby is stable, you can place the baby skin to skin contact with the mother immediately after birth, or you can place the baby in a radiant warmer, and the temperature of the delivery room should be 25 to 28 degrees Celsius. That also is asked in questions. So thermal care is very important, right? Record birth weight. Birth weight again is important, okay? Injection vitamin K 1 milligram intramuscularly is to be given to all babies at birth, all babies. Why? To prevent hemorrhagic disease of newborn, okay? So all babies should receive injection vitamin K intramuscularly at birth. Nowadays, in most of the NICUs, they've also started giving hepatitis B vaccine immediately after birth. Because sometimes what happens, unbooked mothers come and we do not know their hepatitis B status. So if you will given a hepatitis B vaccine to the baby immediately after birth, it will decrease the chances of transmission of hepatitis B from the mother to the baby. Care of umbilical cord, we already mentioned delayed cord clamping for at least 60 seconds. Now this has been included in the latest 2025 neonatal resuscitation guidelines that we'll discuss. So delayed cord clamping for at least 60 seconds for all babies if they are stable, of course. Care of the eyes, you can gently clean the eyes with 2 separate wet sterile swabs. You can clean the eye. Infection prevention, you have to take strict aseptic precautions and assessment of health problems, ongoing monitoring, safe referral when needed. So you can see care of ears as such not included in essential newborn care. Bathing of the child is not included. It is always better to postpone bathing, okay, till the umbilical cord stump falls off. Initial 24 to 48 hours, you just dry the baby, okay, you remove the secretions, nothing else needs to be done. And then 48 hours later you can resort to some sponging and all, but bathing of the baby is usually postponed, never done in the first 24 hours, okay, because there is a risk of hypothermia to the baby. So coming to the options, so cleaning the eyes with a wet sterile swab, is it considered harmful? No, this can be done. Giving a bath immediately after birth, absolutely no. right? We do not want the baby to be hypothermic because neonatal hypothermia can have serious consequences. Initiating breastfeeding within 1 hour is a very good practice that should be promoted. Placing the baby on mother's chest should be done. After normal delivery, it can be very easily done, right? So the best answer here, as rightly said by all of you, giving a bath immediately after birth should not be done, okay? So that is very, very important. Now, what do you mean by hypothermia in a neonate? So neonatal hypothermia. What do you mean by neonatal hypothermia? So it is a condition where the axillary temperature, mind you, we take the axillary temperature of a neonate is less than how much? Less than 36.5 degrees Celsius. So 36 to 36.5 degrees Celsius is cold stress, 32 to 35.9 is moderate hypothermia, and severe hypothermia in a newborn. So severe hypothermia, who can tell me? This has come as a question previously. Severe hypothermia in a neonate is how much? Axillary temperature of a neonate less than, yes, waiting for your answers. So it is less than 32 degrees Celsius, okay. Severe hypothermia in a neonate is axillary temperature less than 32 degrees Celsius. Very good, okay. Now there is something called warm chain that is also sometimes asked. We all know cold chain. So cold chain we know is used for keeping the vaccines in 2 to 8 degrees Celsius. So a cold chain is maintained so that the potency of the vaccines is not lost. Warm chain is to prevent hypothermia in the baby, to prevent neonatal hypothermia. So it is a series of 10 interlinked steps that are done to prevent neonatal hypothermia, right? So what are they? So it should be a warm delivery room, warm resuscitation. So you have to pre-warm, you have to switch on the radiant warmer before receiving the patient. The linen in which you are receiving the patient should be pre-warmed. You have to immediate drying, skin to skin contact between the baby and mother. Breastfeeding, the breast milk also comes at a higher temperature, around 37 degrees Celsius. So breastfeeding should be done, postpone bathing and weighing should be done. Appropriate clothing and bedding should be done. Keep mother and baby together, warm transportation, and you have to generate awareness that it is very, very important to prevent hypothermia in neonates, right? So this is the warm chain. So this skin to skin contact is called kangaroo mother care. So kangaroo mother care is usually done for low birth weight babies, stable low birth weight babies. But this skin to skin contact that we are telling, it is immediately after birth. It is done even for term babies with good weight. Immediately after birth, the baby is placed on mother's abdomen or chest in skin to skin contact for the immediate thermal protection till the time you are, clothing up the baby and all. And kangaroo mother care, on the other hand, is when, the baby is kept in skin to skin contact with the mother, usually done for stable low birth weight babies, and it is done for 8 to 10 hours per day. It helps in the growth of the baby, decreases chances of infection, more exclusive breastfeeding rate, shorter duration of hospital stay, and so on, okay? Right. So, identify the abnormality in the following X-ray of a newborn with respiratory distress. A very, very important spotter has come multiple times, right? So, what do you see here? So, you can see, yes, kangaroo mother care can be given by father also, but of course, the breastfeeding part will not be happening. So, here, of course, we can see that there are bowel gas shadows in the thorax. Can you see the bowel gas shadows in the thorax? You can see that there is no diaphragmatic outline that you can see here. So, this side you can see this diaphragm. But on this side, there is no diaphragmatic border or outline that you see. And there is mediastinal shift. So, this is the left side, this is the right side. There should have been heart shadow here, but you cannot see here because mediastinum has shifted, right? So, this is a condition which is congenital diaphragmatic hernia, we all know. Yes, I can see all of you answering correctly. Very good. So, tracheoesophageal fistula is a separate condition where, the esophageal atresia can be there and a communication between trachea and esophagus. It will not present with these bowel loops in thorax. Respiratory distress syndrome mainly seen in preterm babies due to deficiency of surfactant, and ground glass haziness of lungs is there. Congenital cystic adenomatoid malformation remains a close differential because in that also you can see cystic shadows in the lungs. But what will happen there? In congenital cystic adenomatoid malformation, you will see an intact diaphragmatic border which is missing here. Okay, so it is not congenital cystic adenomatoid malformation. So, congenital diaphragmatic hernia is most common on the left side. It is more common on left side. The most common variety is posterolateral or Bogdalek variety. posterolateral or Bogdalek variety, right? And you know how do you, so you can pick it up on an antenatal ultrasound also. Good antenatal ultrasound can pick it up. Postnatally, how do you diagnose it? So by a triad of clinical features. So what will the baby have in the neonate? There will be respiratory distress, scaphoid or scooped out abdomen because the abdominal contents have moved into the thorax, and mediastinal shift. So if you are getting this triad of findings, we will suspect congenital diaphragmatic hernia. It is very, very important to suspect congenital diaphragmatic hernia because, as rightly said by many of you, we know bag and mask ventilation is absolutely contraindicated. Absolutely contraindicated in congenital diaphragmatic hernia because the condition of the baby, instead of improving, may worsen if you do bag and mask ventilation. So what do? So if the baby has severe respiratory distress, a baby with congenital diaphragmatic hernia, you would rather intubate the baby and do bag and tube ventilation. Okay, we will not do bag and mask ventilation. And in congenital diaphragmatic hernia, there is also pulmonary hypoplasia. So pulmonary complications are the most common cause of death in these babies. Okay, so pulmonary hypoplasia is there, right? Now, moving ahead, so a neonate was brought with a history of frothiness from the mouth. So why frothiness? Because probably the newborn is not able to swallow his or her own secretions. So frothiness is there and respiratory distress is there. An X-ray of the child is given below. So what you can see in these X-rays, we can see that the lungs are okay as such. Heart shadow also looks okay. But what you can see is there is coiling of this feeding tube. You can see this feeding tube is coiled here. Coiling of this feeding tube in the upper part of the esophagus. And why is this coiling there? Because you know the feeding tube cannot go beyond that because of the esophageal atresia. So this is a baby with esophageal atresia with tracheoesophageal fistula. Why tracheoesophageal fistula? Because we can see here gas shadow is present. So probably there is some communication between the esophagus and the trachea, even though the baby is not able to swallow properly. Okay, so coiling of feeding tube is what you see here. It is not transient tachypnea of newborn. Frothiness of mouth will not be present in transient tachypnea of newborn. There only the baby will have some respiratory distress because of delayed clearance of lung fluid. Hyaline membrane disease again is same as respiratory distress syndrome, where you will get ground glass haziness of lungs, and it will be in preterm babies due to deficiency of surfactant. Bogdalek hernia, we already saw how congenital diaphragmatic hernia is going to present. Okay, so very important to understand all the options before you answer. Can you tell me what is the diagnosis here? So I will give you a little background. So this is a preterm baby born at less than, so it is the baby born at around 30 weeks gestation, and the baby is having respiratory distress immediately after birth. Immediately after birth. Yes? So this is very good. I can see people answering. So, and what you see here is this is ground glass haziness of lungs. You can see the lungs are hazy. Lungs are less black. Why less black? Because there is alveolar collapse due to deficiency of surfactant. Normally the lungs appear black because of the air in the alveoli. Here the alveoli are collapsed, less air in the alveoli, so ground glass haziness of lungs. And there is presence of air bronchogram. So yes, this is respiratory distress syndrome or hyaline membrane disease, which is due to the deficiency of mature surfactant. Okay, due to deficiency of mature surfactant. What is the score used for quantifying respiratory distress in this baby? So it is the Silverman score. Silverman score is used. Okay. What is the treatment of choice? Treatment of choice for respiratory distress syndrome. So in mild cases, we give CPAP. What is CPAP? Continuous positive airway pressure. And moderate to severe cases, we need to give surfactant. So moderate to severe cases, we will give surfactant, right? And surfactant, how is it given? It is given intratracheally, not intravenous, not intramuscular, not orally, it is intratracheally. So there are some techniques for giving surfactant. One is the insure technique. What is insure? Insure means, yes, not a insurance, of course, it is intubate, give surfactant, extubate. Okay, intubate, give surfactant and extubate. Okay, nowadays newer techniques have also come like LISA, less invasive surfactant administration, or MIST, minimally invasive surfactant therapy. Okay, right? Now, to prevent respiratory distress syndrome in a preterm baby, we can use antenatal steroids. Now, question comes on which steroid to use. So, you can use either injection betamethasone or dexamethasone. Betamethasone has got fewer side effects, so it is preferred, but dexamethasone is cheaper and more easily available, so that is recommended in the Indian guidelines. So, the dose betamethasone 12 milligram, 2 doses 24 hours apart. Okay, dexamethasone 6 milligram, 4 doses 12 hours apart. So, it is to be given to all, mothers expected to deliver between 24 to 34 weeks gestation, and it is going to decrease the risk of respiratory distress syndrome, decrease the risk of NEC, decrease the risk of intraventricular hemorrhage, and decrease overall neonatal mortality in preterm babies. So, that is why we give it, right? What do you see here? So, this is a baby born at 38 weeks gestation. So, so many case scenarios can come from neonatal respiratory distress. So, this is a baby born at 38 weeks gestation and born through meconium stained liquor. The baby has respiratory distress soon after birth, and when you saw the baby has increased anteroposterior diameter of the chest. Okay. So, what is your diagnosis here? And you can see some heterogeneous pulmonary infiltrates are there. You can see hyperinflated lungs. So, your diagnosis here of course is meconium aspiration syndrome. Okay, so this is a typical case scenario, very good when you will suspect meconium aspiration syndrome. And you may have to give respiratory support, oxygen, you may have to resort to high flow nasal cannula or even mechanical ventilation in these babies, right? Okay. Now, moving ahead, infant of diabetic mother is at risk of developing which of the following? So, is it hypoglycemia, hyperglycemia, anemia or diarrhea? So, the mother has diabetes or high blood glucose. So, please do not jump and mark hyperglycemia in the baby. So, I can see most of you answering correctly. Very good. Karam, Aswathi, Akil, Kartike, Irfan. So, I am not able to read all the names, but I can see most of you answering correctly. That's very, very reassuring. So, a little bit about infant of diabetic mother. So, there is mother has diabetes. So, mother has high blood glucose. So, fetus will also have high blood glucose. So, fetal pancreatic beta cells will get stimulated and it will produce excess insulin. So, fetal hyperinsulinemia will be there. And we know insulin is a growth factor for fetus. Insulin is a growth factor for fetus, right? So, excess insulin means excess growth. So, the baby will have macrosomia. It will be a large fodate baby. So, remember, growth hormone has no effect on the growth of fetus. It is the other hormones like insulin, steroid hormones, thyroxine, they affect the growth of the fetus more. Okay. So, risk is more in mothers with pre-existing diabetes and especially poorly controlled. So, pre-existing poorly controlled diabetes rather than gestational diabetes. Okay. And of course, we will have macrosomia or large fodate baby. What is the problem if the baby is large? More chances of obstructed labor and difficult delivery. More chances of obstructed labor. So, difficult delivery, birth trauma, okay, difficult delivery, birth trauma, right? Birth trauma will be there, and more chances of perinatal asphyxia, okay, more chances of perinatal asphyxia will be there, right? What else? There can be some metabolic problems, some hypos. So, why hypo? Because the fetus is having hyperinsulinemia. Now, what is happening when the baby is born? Insulin levels in the baby are still high, but the excess blood glucose that was coming from the mother is no longer coming. So, less sugar coming, more insulin. So, the baby is going to have hypoglycemia. Some more hypos that can happen: hypocalcemia, hypomagnesemia. So, these babies can have seizures, and you have excess of RBC production, so polycythemia, and more chances of hyperbilirubinemia or jaundice, right? So these are the metabolic problems among the cardiovascular problems. So overall, you know, the most common congenital abnormality in infant of diabetic mother is congenital heart diseases, okay? So increased chances of congenital heart diseases. Among the congenital heart diseases, most common would be VSD, ventricular septal defect, but most specific for infant of diabetic mother would be TGA or transposition of great arteries, okay? Respiratory, you know, they have more chances of increased risk of RDS, respiratory distress syndrome, even in term babies due to delayed maturation of surfactant. Delayed maturation of surfactant, okay? If you look at CNS problems, overall the most common congenital CNS abnormality in these babies is neural tube defects. But the most specific abnormality in infant of diabetic mother is, yes, what is it? So it is sacral agenesis, or it is also called caudal regression syndrome. So that is the most specific abnormality in infant of diabetic mother. Long-term problems can also happen like blindness in the baby, obesity, and diabetes mellitus when the baby grows up, right? Moving ahead, you have a newborn born to a diabetic mother presenting after 24 hours of life with a blood glucose of 40. So blood glucose less than 45 mg per dl, some sources say even 50 mg per dl is hypoglycemia in a neonate. Now the baby is asymptomatic. What is the next best step in management? Yes. So I can see, so here there is some variation in the answers that I am getting. So let us first discuss about this neonatal hypoglycemia management, then we come back to answer this question. So how do you manage hypoglycemia in a neonate? Okay. So what we do is we first see whether the baby is symptomatic or asymptomatic. Okay. So if the baby is symptomatic, that means the baby is having seizures, apnea or some other problem because of the hypoglycemia. Baby is symptomatic. What do we do? So we will straight away give IV 10% dextrose. Okay. And we will start continuous GIR, glucose infusion. Okay. We will continuous dextrose infusion. We will start and recheck blood glucose, of course. Recheck blood glucose and keep monitoring, okay? But if it is a asymptomatic baby, what do we do? Asymptomatic baby, we will offer a feed and recheck blood glucose, okay? Recheck blood glucose after say half an hour or so. If the blood glucose has improved, if the glucose is now normal, you continue frequent feeding and monitor, okay? But if it is still low, then you have to give IV 10% dextrose and start infusion. So normal blood glucose in a neonate would be anywhere between, so it should be more than 50 mg per dl and it could be up to 150 mg per dl to 200. So we will call it hypoglycemia if the blood glucose, some sources say it is less than 50 mg per dl, some sources say less than 45 mg per dl. Then we will call it hypoglycemia in a neonate. So if the blood glucose is very low, say less than 20, then again we are not going to wait, we will start 10% dextrose if the blood glucose is very low, okay, right? So here what is seen, so here the blood glucose is 40, it is not like very low, less than 20 is not there, so we need not give IV and the baby is asymptomatic. So IV 10% dextrose bolus is still not required. Do nothing, just check blood glucose? No, doing nothing is not going to raise the blood glucose value. Administer IV glucose recheck? No, we are not going to administer IV. We will offer a feed and recheck blood glucose after 10, 20 to 30 minutes. So that is the best answer here. So I hope now you will get the answer correctly. Okay, right? So different sources give different answers. The cutoff for blood glucose in hypoglycemia in neonates. So some sources say less than 50 mg per dl, some sources say less than 45 mg per dl. So usually you will not get a question where it is asking a direct cutoff, okay? But if you have to go for with one answer, you can take 45 mg per dl as the answer. If that is not there in the option, then 50 mg per dl, okay? What do you mean by a post-term neonate? So there are some terminologies that we need to know. So preterm neonate is a neonate born at less than 37 completed weeks of gestation. Okay. Post-term neonate is a neonate who is born at greater than equal to 42 completed weeks, greater than equal to 42 weeks of gestation. Right. So beyond 42 weeks is a post-term neonate. So term neonate would be a neonate born anywhere between 37 to 42 weeks of gestation. Then there are some terminologies like small for gestational age baby is a baby whose birth weight is less than 10th percentile of expected according to the gestational age. Okay. Large for date baby will be a baby whose birth weight is more than 90th percentile of expected according to the gestational age. Okay. So these simple terminologies we need to remember. Then low birth weight baby is a baby whose birth weight is less than 2500 grams. Very low birth weight baby is a baby with birth weight less than how much? Birth weight less than 1500 grams. And extremely low birth weight baby is a baby with birth weight less than 1000 grams. So these are some very important terminologies, basic terminologies that we need to remember. Of course, the post-term neonate can have, some features like peeling of skin, long hair, long nails, abundant hairs, and so on. Okay? Right? A newborn baby. So, a newborn baby. So, Irfan is asking the drug of choice for resistant hypoglycemia. So, if a baby has got persistent hypoglycemia, we need to work up the baby for an underlying inborn error of metabolism can be there, or there can be some endocrine abnormalities like hyperinsulinemia. There is something called persistent hyperinsulinemic hypoglycemia of infancy, right? So in those cases, we might have to resort to drugs like octreotide, diazoxide and so on, okay? So in that case, of course, usually the drug of choice is octreotide, okay? So, a newborn baby was born limp and having apnea. On examination, the heart rate was 80 per minute. What will you do next? So, baby is born limp and having apnea means not breathing. Heart rate is 80 per minute. What will you do next? So, will you start chest compressions, give oxygen, umbilical vein catheterization, bag and mask ventilation? So, before I answer this question, again here I see a difference in opinion. So, some of you are answering correctly, some are not. So, let us first discuss about the neonatal resuscitation guidelines. Then we will come back to answer this question. Okay. So, what we are discussing here is the latest 2025 neonatal resuscitation guidelines. Okay. So, let us first discuss this, then we come back to answer this question. Okay. So, here the neonatal resuscitation guidelines again start from antenatal counseling, team briefing and equipment check just like in the previous guidelines. Then is the birth of the baby. What is new added here is initiate cord management plan. So, this step was not there in the previous guidelines. So, this initiate cord management plan has been newly added here. Okay, so you have to, if the baby is stable, you have to plan for delayed cord clamping for at least 60 seconds. If the baby is not stable, you may consider cord milking if the baby's gestational age is more than 28 weeks. But less than 28 weeks, no cord milking is to be done. Okay. So, initiate cord management plan has been newly added. Then, term gestation, good tone, breathing or crying, it is just like the previous guidelines. If the answer to all this is yes, the baby gets routine care. Okay. So, that means skin to skin contact and maintain normal temperature, ongoing evaluation, dry the baby and so on. If the answer to any of these questions is no, then what do? Warm and maintain normal temperature, dry position, stimulate, clear airway. The terminology suction has been removed from here. Okay, clear airway has been written. Suction has no longer been written in the guideline here. Okay. What else? Now, if the baby is having apnea or gasping or heart rate less than 100 per minute. So, in our case scenario, remember the baby is having apnea and the heart rate in our case scenario is 80 per minute. That means it is less than 100 per minute. So, what will you do? You have to ventilate. You have to connect a pulse oximeter and you have to consider using a cardiac monitor for accurate heart rate estimation. So, another change that has been there in this latest guidelines is initiate positive pressure ventilation Instead of that, the terminology now used is ventilate. So you will ventilate the baby. So we are doing the same thing, but instead of positive pressure ventilation, now the guideline mentions it as ventilate. Okay. If the baby does not have apnea, gasping, heart rate less than 100 per minute, then what do? So it is just labored breathing or persistent cyanosis. You see if it is there or not. If it is there, then pulse oximeter, oxygen if needed, and consider CPAP. What is CPAP? Continuous positive airway pressure. Okay. Now, if you've started ventilation, connected a pulse oximeter and cardiac monitor, then again we'll see if the heart rate is less than 100 per minute. If the answer is yes, we take ventilation corrective steps, consider intubation or laryngeal mask airway and cardiac monitor. So this use of laryngeal mask airway here has again been highlighted in the latest guidelines. Okay. Now what else? If the heart rate is less than 60 per minute, you will intubate or use a laryngeal mask airway. Chest compressions coordinate with positive pressure ventilation. The ratio we know between chest compression and positive pressure ventilation will be 3:1. You have to insert a umbilical venous catheterization and you have to use 100% oxygen here. Okay. Now another change that has been there in the recent guidelines is the target oxygen saturation table now starts from 2 minutes of life instead of 1 minute. So previous guidelines, there was also a value at 1 minute, that was 60 to 65%. But in the latest guidelines, the table starts from 2 minutes, right? So 2 minutes, the target oxygen saturation is 65 to 70%. Yes, the cutoffs remain the same, but the table or the monitoring of saturation now starts at 1 minute. Why? Because it is recommended that in the first minute, you don't have time to measure the saturation actually. So in the first minute, what we were doing is, so first minute is called the golden minute of life. So in the first minute, if the baby is having apnea or gasping or heart rate less than 100 per minute, you have to start positive pressure ventilation. No need to check the saturation. You have to start positive pressure ventilation. So it is the golden minute of life. Monitoring of saturation begins from 2 minutes onwards. Okay. Now coming back to our case scenario. So here the baby is having apnea and heart rate was 80 per minute. So what do you do next? So chest compressions, no, it is required only if the heart rate is less than 60 per minute. Give oxygen, again giving oxygen is not required. We will also be discussing about the use of oxygen in neonatal resuscitation. Umbilical vein catheterization will be later required if epinephrine is required to be given. So bag and mask ventilation is the correct answer here. Okay, clear? Moving ahead. According to the neonatal resuscitation protocol, so chest compression is initiated at heart rate below how much? Yes. So chest compression is, is required at heart rate less than. So this I am sure all of you will answer correctly. Yes, I can see all of you answering correctly. Very good. So it is less than 60 per minute, only then we start chest compressions. Clear? Now, according to neonatal resuscitation protocol, how much oxygen is given in a term neonate with apnea and bradycardia initially? Yes. So regarding the use of oxygen. So whenever we start, even if we start positive pressure ventilation, bag and mask ventilation for a term neonate, we start with room air. No need to connect oxygen to the bag and mask, right? No, it's not 100% Nikhil and Siddhant. So I can see some of you answering correctly. So the correct answer here is Rajan, and I can see SK Nib, Kushagra, and I can see Shivamutha, Ashish. So correct answer here is 21%. So initially, whenever we are starting positive pressure ventilation, we use room air. Room air has 21% oxygen for a term baby. Okay. Only if chest compressions are required, then we will go ahead and give 100% oxygen. Okay. So regarding the use of oxygen in neonatal resuscitation, it is recommended that in term and late preterm newborn infants, we start with 21% oxygen, that is room air. Okay. So that is room air. In babies 32 to 35 weeks of gestation, we start with 30%. 21 to 30%. Okay. 32 to 30 weeks gestation, 35 weeks gestation, we start with around 30%. Okay. And in very preterm babies, less than 32 weeks gestation, we can we can give more than 30%, we can even give up to 100%, okay, right, greater than 30%. So that is about the latest guideline of use of oxygen in neonatal resuscitation. So in term and preterm neonates, 21% oxygen, 32 to 35 weeks gestation, we can give up to 30% oxygen, and very preterm babies less than 32 weeks may need more than 30% oxygen for resuscitation, okay. So it will be better put as more than 30% oxygen, right. How to measure oxygen saturation in newborn has not been asked till now, but it's a potential question. So of course, we'll use a pulse oximeter, and what is to be measured ideally is pre-ductal oxygen saturation. So that means you will put the pulse oximeter in the right hand. Why pre-ductal? Because pre-ductal, before the ductus arteriosus, the branches of arch of aorta come, right? What are the branches of arch of aorta? Brachiocephalic trunk, left common carotid, left subclavian. So you know the structures of head and neck and heart are getting pre-ductal blood. So we need to monitor the pre-ductal oxygen saturation to get a good idea about how much oxygenation is the heart and brain receiving. So we will connect the pulse oximeter ideally to the baby's right hand, okay. Now, a 4-week-old infant presents with high conjugated bilirubin, dark colored urine and clay colored stools. On examination, the infant appears jaundiced but is feeding normally. What is the most likely diagnosis? So it is a 4-week-old baby. Conjugated bilirubinemia is there. The urine is dark colored and clay colored stool are there. So that means there is some sort of obstructive jaundice. The baby is appearing jaundiced but is otherwise feeding normally. So the most likely diagnosis, I can see most of you answering correctly. Yes, very good. So it is biliary atresia. So out of the given causes here, biliary atresia is the one which has conjugated hyperbilirubinemia. Rest all glucose 6-phosphate dehydrogenase deficiency causes hemolysis. Whenever there is hemolysis, increased production of bilirubin, and the bilirubin that is produced initially is unconjugated, okay. So here mainly it will be unconjugated hyperbilirubinemia. Same with Crigler-Nazar, the UDP glucuronidase transferase enzyme activity is low, so it will also, all these will produce unconjugated hyperbilirubinemia. So urine will not be dark colored, pale colored stools will not be there. Physiological jaundice again is unconjugated hyperbilirubinemia. So our best answer no doubt here is biliary atresia, okay. How do you distinguish physiological jaundice from pathological jaundice of newborn? Very important potential question. You get true or false questions and so on. So remember, physiological jaundice, in this the baby will never appear yellow or icterus will never develop in the first 24 hours of life. So clinical jaundice never appears in first 24 hours of life. But in pathological jaundice, clinical jaundice may appear in first 24 hours of life. Physiological jaundice, palms and soles never stained yellow. So physiological jaundice is never very severe. So palms and soles not stained yellow. Because you know jaundice in newborns has a cephalocaudal progression. That means if the jaundice is very mild, only the face is yellow. More severe chest is yellow, more severe abdomen is yellow and so on. In most severe jaundice, the palms and soles are yellow. Physiological jaundice, anything physiological will never be very severe. So in physiological jaundice of newborn, palms and soles are not stained yellow. But pathological jaundice, palms and soles may be stained yellow. Yes, very good. So it is called Kramer's rule in Shah. Cephalocaudal progression of jaundice. So Kramer's rule, you can get an idea about the bilirubin level of the baby. Like if only the face is yellow, the bilirubin level is 4 to 6 milligram per dl. Chest is yellow, it is 8 to 10 milligram per dl. Abdomen is yellow, 10 to 12 milligram per dl. If the palms and soles are also yellow, the bilirubin level is greater than equal to 15 milligram per dl. So that is the modified Kramer's rule. Okay. So what else? Physiological jaundice is always unconjugated. So in physiological jaundice, you know what will happen? The palms and soles are never stained yellow. Palms and soles are, so, and the urine is not yellow. So urine is not high colored, okay? Because we know unconjugated bilirubin cannot go in urine, okay? Right? And what else? Physiological jaundice usually subsides by 3 weeks age. But pathological jaundice may remain for a longer time. right? So that is how clinically you can distinguish from a given case scenario whether it is physiological jaundice or pathological jaundice. Okay. Now about biliary atresia, a few important points that are sometimes asked, though it is discussed more extensively in surgery. Screening test for biliary atresia or extrahepatic biliary atresia is the HIDA scan or hepatic scintigraphy, radionuclear based scan. Okay, surgery for EHBA we know is Kasai's procedure or Kasai's portoenterostomy. Okay, and it has best prognosis or outcome if done at less than 8 weeks, before 18 weeks, before 8 weeks age, right? Most common indication for liver transplantation in children. So again, most common indication for liver transplantation in children is biliary atresia. Okay. Kasai procedure is only a palliative procedure, not a curative one. The curative thing is going to be liver transplantation. Okay. Now moving to some topics in general pediatrics, right? So, match the following with respect to the following chart depicting various growth patterns, right? So, what you can see here is some graphical forms are given, okay? So, you can see that graph A is showing what? So, it is showing maximum growth. So, graph A is showing maximum growth in the 4 to 8 years, okay? So, this coincides with what? Lymphoid growth, okay? So, lymphoid growth shows this peak in this age group. So, you can get physiologically enlarged tonsils in this age group, okay? What else? So, graph B is showing that maximum growth, graph B is showing that maximum growth is there in the first 2 years, first 2-3 years, and then there is a plateau. So, CNS growth or brain growth is what is depicted in graph B, right? Graph C is showing somatic growth because initially in infancy a period of accelerated growth, then slow growth, then again accelerated growth, okay? So, this is somatic growth, and gonadal growth is shown in graph D. Gonadal growth in graph D, right? Because after puberty, so not much growth happening till first 10-11 years of life and then suddenly increased growth or development. So, this is gonadal growth. So, our best answer is A with 2, A with 2, B with 3, C with 4 and D with 1. So, option A is the best answer here, right? So, your concept should be clear, then you can answer this question related to growth. Yes. And brain growth, as rightly said by Faizu, so maximum amount of brain growth happens in the first year of life, okay? Now, which is the first tooth to appear in a child? So, the first tooth to appear in the child, yes, I'll be waiting for your answers. In the meantime, let us discuss a little bit about normal dentition. So, normal dentition, you have a primary dentition and a secondary dentition. So, primary dentition, it is also called milk teeth. Secondary dentition also called permanent teeth. Okay. Primary dentition begins at 6 months age, usually 6 to 7 months, and the first tooth to appear in primary dentition is lower central incisor. Secondary dentition usually begins at around 6 years age, and the first tooth to appear in secondary dentition is the first molar. The last tooth to appear in the primary dentition, a bit confusing, but it is the second molar, while the last tooth in the secondary dentition is the third molar or wisdom tooth. Third molar or wisdom tooth, okay? Now, primary dentition is usually completed by 2.5 to 3 years. Secondary dentition usually completed by 12 years except the third molar or wisdom tooth which come at 18 to 25 years of age and may not erupt in some of us also, right? That doesn't mean that we are not wise, but yes, wisdom teeth might not come, right? Total number of teeth in primary dentition is 20, in secondary dentition it is 28 to 32 depending on the number of wisdom teeth that have come. When do you call it delayed dentition? So, we call it delayed dentition when no tooth has erupted even beyond 13 months age. No tooth even by 13 months. Only then we call it delayed dentition, Okay. So which is the first tooth to appear in the child? The answer becomes lower central incisor. If the question has been which is the first permanent tooth to erupt in a child, then it would be what? It would be first molar. Okay. Last tooth to erupt, last milk tooth to erupt is the second molar. Last permanent tooth to erupt is the third molar. Okay. So calculate the mid-parental height. Mid-parental height for a male child with a father who is 180 centimeter tall, mother who is 170 centimeter tall. Yes. So how do you calculate mid-parental height? A little bit of mathematics in pediatrics. So please calculate before giving your answers. So in boys, the mid-parental height is what? Father's height plus mother's height plus 13/2 in centimeters. For girls, it is father's height plus mother's height minus 13/2 centimeters. So because this is a boy, yes, and in other words, of course, you can write it as average of height of parents plus 6.5. So that is another way of writing the same formula. Okay, you can write it like this also. Okay. So let us see in our question. So it is a boy, male child is there, right? So the mid-parental height is going to be father's height plus mother's height plus 13/2, or the average of parents' height plus 6.5, right? So it is going to be 180 plus 170 plus 13/2. So it is how much? Or you can write it as the average of parents' height is how much here? So it is 180 plus 170/2 plus 6.5 centimeters. So it is 350/2 plus 6.5. 350/2 is 175 centimeters plus 6.5. So it is 181.5 centimeters. So our best answer is option A here, right? नहीं, मैथ्स इक्वेशन गलत नहीं हुई, बिल्कुल सही है. आपने इन दोनों को लिया और 13/2 is 6.5. Yes. So आपने average, you have taken the average of parents' height and you have added 6.5 to here. ठीक है, तो आपका 181.5 centimeters आया, right? Okay. So mid parental height gives the target height of the child. कि the child's height should be around, the adult height of the child should be around this height. Okay. So again another question on short stature. So you have so the most important part in pediatrics definitely is the core general pediatrics. So we will be focusing a lot on that, right? So a 7-year-old child presents with short stature. So short stature means, what do you mean by short stature? So it is height of a child less than 3rd percentile or less than -2 z-score or standard deviations based on age or sex, age and sex of the child. On evaluation, the bone age is found to be less than the chronological age. Yes, so bone age is less than the chronological age. And there are no dysmorphic features. The child is otherwise healthy. Height of his parents is normal. What is the most likely diagnosis? So waiting for your answers. Before that, yes. So mid-parental height, someone wants me to repeat once. एक बार वापस जाते हैं. Mid-parental height for boys it is, for boys mid-parental height is father's height plus mother's height plus 13/2. Okay. Father's height plus mother's height plus 13/2 in centimeters. Girls के लिए it is father's height plus mother's height minus 13/2. So in this case scenario, the father's height is 180. Mother's height is 170, उसमें 13 add कर दो, add all this and divide it by 2, your answer will come as 181.5. ठीक है, right? So अगर देखो आप, so if you write 13 like this, पूरे के नीचे 2 लगा दो अगर आप, तो it will be 13, है ना? और 13/2 क्या होता है बताओ? 13/2 6.5 होता है. तो अगर आप 13 को यहाँ से हटा दिया, आपने 13 अलग कर दिया, तो ये 6.5 बन जाएगा. तो ये है या तो 13/2 और या फिर ये ओनली 6.5, है ना? 13/2 6.5 होता है ना. सो यू कैन आइदर इंक्लूड इट विद अ डिनोमिनेटर ऑफ 2, 180 प्लस 170 प्लस 13/2, इकट्ठे सबको ऐड करके 2 से डिवाइड कर दो, या फिर आप कर दो पेरेंट्स के हाइट का एवरेज निकाल लो और उसमें 6.5 ऐड कर लो. दोनों में से जो ईजी है आपके करने के लिए, दोनों ओके है. या तो मदर्स हाइट प्लस फादर्स हाइट प्लस 13 और पूरे को 2 से डिवाइड कर दो, या फिर आप एवरेज ऑफ पेरेंट्स हाइट निकालो और उसमें 6.5 ऐड कर दो. दोनों इक्वेशंस सही है, राइट? ओके, सो तो इस क्वेश्चन में कमिंग बैक, सो लेट अस फर्स्ट डिस्कस अ लिटिल बिट अबाउट फेमिलियल शॉर्ट स्टेचर एंड कंस्टिट्यूशनल डिले इन ग्रोथ एंड प्यूबर्टी, देन वी कम बैक टू आंसर दिस क्वेश्चन. सो गर्ल चाइल्ड के लिए बस वो 13 को माइनस करना है. वैसे गर्ल चाइल्ड के लिए मिड पेरेंटल हाइट में आपको एवरेज ऑफ पेरेंट्स हाइट निकालो minus 6.5. You take out the average of parents' height and you subtract 6.5 from that. Then you will get mid-parental height in girl child. Okay? Okay. So this constitutional delay in growth and puberty may, what happens is, it is the most common cause of short stature during childhood. But remember, I am telling you during childhood. Why? Because the final adult height attained जो है वो normal होगी. So in constitutional delay in growth and puberty, the final height attained is normal. Okay. But in familial short stature, what happens? The final height of the child will be short, but it is normal as per his target height. So we've already seen mid parental height. So mid parental height के around ही target height होती है, plus minus 8 centimeters. So short है बच्चा. So the ultimate final height in familial short stature is going to be short, but it is normal as per the height of parents. मतलब the parents are also short. तो आप देखोगे एक फैमिली में जैसे पेरेंट्स अगर शॉर्ट है तो यूजुअली दोनों पेरेंट्स अगर शॉर्ट है देन द चाइल्ड विल ऑल्सो बी शॉर्ट. तो वो उस बच्चे की नॉर्मल है हाइट, है ना. द चाइल्ड इज शॉर्ट एज पर द ग्रोथ चार्ट्स, बट द हाइट इज नॉर्मल इफ यू लुक एट द हाइट ऑफ द पेरेंट्स. ठीक है. सो यहाँ पे मिड पेरेंटल हाइट की इंपॉर्टेंस है. ओके, राइट. सो द कंस्टिट्यूशनल डिले इन ग्रोथ एंड प्यूबर्टी. So somebody is asking me to tell about cerebral palsies. Okay, तो आप एक बार याद दिलाना मुझे जब पीडियाट्रिक न्यूरोलॉजी हम डिस्कस कर रहे हैं इन सिस्टमिक पीडियाट्रिक्स. ओके, विल कम बैक टू इट. सो कंस्टिट्यूशनल डिले इन ग्रोथ एंड प्यूबर्टी में हमने बोला कि फाइनल हाइट अटेन्ड विल बी नॉर्मल, लेकिन आप ड्यूरिंग चाइल्डहुड इफ यू लुक एट द हाइट्स, द चाइल्ड्स हाइट इज लेस देन एक्सपेक्टेड. पेरेंट्स हाइट नॉर्मल होगी कंस्टिट्यूशनल डिले इन ग्रोथ एंड प्यूबर्टी में. द पेरेंट्स हाइट इज नॉर्मल. प्यूबर्टी विल बी डिलेड and bone age will be less than the chronological age. क्योंकि skeletal maturation will be delayed है, puberty भी delayed है, सब कुछ delayed है. Constitutional delay in growth and puberty, the name itself is telling you there is a delay. तो bone age will be less, puberty will be delayed, but ultimately देर से आएंगे but पहुंच जाएंगे. So the ultimate final height attained is going to be normal. Okay? Familial short stature में क्या होता है? The child will remain short and but it will be normal if you look at the height of their parents. So यहाँ पे the parents height is also less. Age at puberty is normal, no problem with puberty, no problem with skeletal maturation. So bone age will be equal to the chronological age. Okay. So coming back to our question, here the child is having short stature during childhood. Child is short, bone age is less than the chronological age. Dysmorphic नहीं है, height of parents is normal, so it is not familial short stature. The most likely diagnosis, as rightly pointed by most of you, it is constitutional delay of growth and puberty. So chronological height means the height which should be there at that age. Chronological height, so this bone age is less than the chronological age. Chronological, chrono मतलब number होता है ना. Chronological age means जैसे उसके डेट ऑफ बर्थ के हिसाब से व्हाट इज द एज ऑफ द चाइल्ड. सो एज ऑफ द चाइल्ड बेस्ड ऑन हिज डेट ऑफ बर्थ इज क्रोनोलॉजिकल एज. You can estimate the age of the child looking at the X-rays, looking at the ossification of the various epiphyses. उसको we say the bone age. Forensic में also you would have learned that looking at the bones, looking at the X-rays, you can make out the child's age. That is bone age. Chronological age is the age based on the date of birth. Okay. So constitutional delay of growth and puberty is our best answer. Familial short stature, no, because the height of parents is normal. Achondroplasia, no, because achondroplasia is a condition of disproportionate short stature where the limbs are shorter than the rest of the body and there will be some dysmorphism. Osteogenesis imperfecta also no, because you get blue sclera and a lot of a triad of findings. क्या मिलता है osteogenesis imperfecta में? So osteogenesis imperfecta is a condition where there is type 1 collagen defect. Multiple types of osteogenesis imperfecta are known. So most of the types have got autosomal dominant inheritance. Okay, and there is a triad of clinical features that you get in osteogenesis imperfecta. What is the triad? So you have blue sclera, Why do you have blue sclera? So because क्या होता है ना, कोलाजन डिफेक्ट है. स्क्लेरा इज मेनली मेड ऑफ कोलाजन. कोलाजन डिफेक्टिव है. So क्या हो रहा है, द स्क्लेरा इज वेरी थिन, सो यू कैन सी द अंडरलाइन कोरॉइड लेयर बिलो इट. सो दैट इज बाय ब्लू स्क्लेरा. सो ब्लू स्क्लेरा है. और क्या है, यू हैव बोनी डिफॉर्मिटीज ड्यू टू रिकरेंट फ्रैक्चर्स. तो इसमें क्या होता है, द बोन्स आर वेरी वेरी फ्रेजाइल. ओके, so bony deformities are there due to recurrent fractures. Okay, and what is the third thing? So there is deafness. Okay, so that is the typical triad that you get in osteogenesis imperfecta. So here osteogenesis imperfecta, mainly the limbs are short. So it is short limb dwarfism. You can get a large head also. Okay. What is this? So you can get an image based question like this. So here you can see that mainly the limbs of the child are short. Okay, the limbs are short. What do you see in the second picture? A hand abnormality which is called the trident hand. Right, त्रिशूल के जैसे hand दिख रहा है. Okay, so it is trident hand. And what you see in this picture is a champagne glass pelvis. Okay, champagne glass pelvis. So all these are features of, yes, achondroplasia. Again, achondroplasia has got autosomal dominant inheritance and it is short limb dwarfism. Who will tell me what will happen to the upper segment lower segment ratio in achondroplasia? What will happen to the upper segment lower segment ratio in achondroplasia? So here what is happening, the limbs are short, matlab the lower segment is less. Because the lower segment is less, the denominator is less, the upper segment lower segment ratio is increased. Very good, Priya, Riya, and we have Ajay, Fit Medicos, Manvi, Manoy, SK Mishba, Shivangi. Yes, so I can see so many of you answering correctly. So upper segment lower segment ratio will be increased in achondroplasia. But in familial short stature, constitutional delay in growth and puberty, they are all proportionate short stature. So upper segment lower segment ratio remains normal in those conditions. Okay, right. Moving on to the developmental milestones. So from growth we move on to development. So what is the likely age of a child who can ride a tricycle, walk upstairs with alternate steps, cannot hop? Okay, so before I answer this, let us quickly discuss and revise some important developmental milestones. Okay, so important gross motor milestones. So neck control, partial is going to come by 3 months, complete neck control usually by 5 months. Sitting with support, so we remember sitting, then standing, then walking. Everything with support first, without support later. So sitting with support around 6 months, sitting without support 8 months, standing with support 9 months, standing without support 12 months, walking with support 12 months, walking without support 13 months, rides its ride cycle at 3 years. Remember, try 3. Similarly, goes upstairs and downstairs 2 feet per step at 2 years, upstairs with alternating feet, downstairs 2 feet per step, 3 years, upstairs and downstairs with alternate feet is 4 years, hops at 4 years. Right? Moving ahead, important fine motor milestones. Holds an object when placed in hand, 3 months. Reaches out for objects, 4 months. Bidextrous grasp, holds with both hands, 5 months. Palmar grasp, 6 months. Transfers objects one hand to another, 7 months. Okay. Immature pincer grasp, 9 months. Mature pincer grasp, 12 months. Scribbles spontaneously, 15 months. Tower of 6 to 7 cubes at 2 years. Handedness appears at 2 years and gets established by 3 years. You are able to know whether it is a right-handed or a left-handed child. So trident hand is abnormality of hand like this. The fingers will be lying oblique to each other. Okay, the fingers will be lying oblique to each other like this. So making an angle with each other. That is trident hand. Okay, Vandana? Right. Drawing skills of a child. So drawing skill, yes. So Akhil has mentioned that number of cubes put in tower is age into 3. Very good. So at 2 years, a tower of 6 cubes. At 3 years, a child can make a tower of 9 cubes and so on. Drawing skills of a child. So a child is able to copy a straight line, vertical or horizontal line at what age? So a line has got 2 ends. So copies a straight line at 2 years. Rectangle has got 4 vertices. So copying a rectangle or a plus sign at 4 years. Circle has got these round things, right? Round. So copies a circle at 3 years. And oblique lines, multiplication sign at 5 years. Okay. Important social milestones. Social smile comes at around 2 months, mirror play 6 months, stranger anxiety by 7 months, waves bye-bye, very important milestone, by 9 months. Plays peekaboo 10 months, plays a simple ball game 12 months, points to objects 15 months, domestic mimicry and dry during daytime at 18 months, parallel play at 2 years, joins in play and dry at night by 3 years, and goes to toilet alone by 4 years, right? So these are some very important social milestones. Moving on to language milestones. So child starts vocalizing or producing some sort of sound by 2 months, cooing or a more musical sound by 3 months, monosyllabic babbling by 6 months, bisyllabic babbling by 9 months, 2 to 3 words with meaning by 1 year, jargon speech by 15 months, 10 words with meaning 18 months, 2 word sentences at 2 years. So number of words put in sentence is equal to age into years. So 2 word sentences at 2 years, 3 word sentences at 3 years, tells a story, rhyme or sings a song at 4 years. And at 2 years, the child has a vocabulary of 50 to 100 words. Okay, the child knows 50 to 100 words with meaning, also knows, pronouns. The child can use pronouns. Moving back to our question. So, what is the most likely age of a child who can ride a tricycle? 3 years. Remember 3 wheels, tricycle, 3 years. Walks upstairs with alternate steps, again 3 years. Cannot hop. Hopping we know comes at 4 years. So the child's age is probably in between 3 and 4 years. So our best answer is B, that is 3.5. So Akhil is asking, what do you mean by red flag? So Akhil, red flag means, the upper limit by which, by that time, if one developmental milestone is not attained, then it is abnormal. So let's try to understand it this way, that for example, sitting with support comes at 6 months. That does not mean कि 6 month 10 days पे, if a child is not sitting, will you say the child has developmental delay? No. So there is a range of time by which, we can wait for that milestone. So sitting with support appears at 6 months, but if it has not appeared even by 8 to 9 months, then we say it is a developmental red flag. That means 9 months, या some books say 8 months. So 8 to 9 months तक भी अगर sitting with support has not come, only then it is a red flag. So red flag is the upper limit of time by which that particular milestone should be attained. If it is not attained, we say the child has developmental delay. Okay, right? Okay. So 8 months may, so there are some, so table, sitting with support. So you can remember, you need not remember the exact values. You can remember that red flag is usually 2 to 3 months more than the usual time of attainment of milestones. So sitting with support comes at 6 months. So if it does not come by 8 to 9 months, it is a red flag. Okay. Similarly, pincer grasp comes by 9 months. If it does not come by 12 months, if it has not come, then it is a red flag. Single meaningful words usually come by 12 months. So meaningful words usually come by 12 months, 2 to 3 words by meaning. If it does not come by 15 to 16 months, then it is a red flag. So it is basically, the time at which the milestone should have come, and you add around 2 to 3 months more than that. Okay. So dentition, okay. So dentition wala term, somebody is asking me to repeat. So it is convenient if you tell me then and there. Okay. But I'll just tell you. So dentition mein kya hota hai? So dentition, milk teeth, first milk tooth to appear 6 to 7 months. First permanent tooth appears 12 months. First milk tooth to appear is the lower central incisor. First permanent tooth is first molar. Last milk tooth, second molar. Last permanent tooth, third molar or wisdom teeth. Total number of milk teeth, 20. Total number of permanent teeth is 28 to 32, right? Depending on the number of wisdom teeth come. So Japanese is asking, is this LRR enough? So, it will cover most of the topics, but LRR is a short concentrated session. So obviously it will not cover everything, but it will cover more than 80% of questions that will come from pediatrics, that we expect from pediatrics. But yes, for best results, you should also go through the rapid revision and PYQs once. Yes? Okay. Moving ahead, a 6-year-old child presents with bedwetting at night. So bedwetting at night, the parents mentioned the child had a fall from bed once, but there was no loss of consciousness or seizures. That means it was probably not a significant fall. He has no other significant medical history. There are no signs of urinary tract infection or neurological deficits. So what is the best next step in management? So first, what is your diagnosis here? So before discussing the management, our diagnosis here of course is nocturnal enuresis. When do you call it nocturnal enuresis? So we call it nocturnal enuresis when there is involuntary urination at night beyond 5 years of age, irrespective of whether it is a boy or girl. For both, the cutoff remains 5 years. So in developmental milestones, we saw that the child usually becomes dry at night by 3 years of age. But if the child continues to void at night involuntarily beyond 5 years, only then we call it nocturnal enuresis. Okay. So एक तरह से nocturnal enuresis में you can say that the red flag for dry at night becomes 5 years. Okay. So males में it is more common than females. Okay. And positive family history is seen in more than 50% cases. Okay, more than 50% cases you will get a positive family history. How do you manage it? So the first line management is not drugs. It is lifestyle changes plus motivational therapy. So what do? So you ask the child to have early dinner, less consumption of fluids after evening, less fluids in evening. Okay. And you have to avoid the intake of a lot of salty or sugary foods, so to prevent osmotic diuresis. Motivational therapy, you make a star chart. Okay, you put a chart on the wall and show the child that for every night the child is remaining dry, you draw a star. And if there are 7 consecutive stars, you get a gift for the child. So that is what is motivational therapy or positive reinforcement. Okay, so that is what should be done. So that is the first line of management. The second line is you can use a bed and alarm technique. So there are some moisture sensing alarms that are available. As soon as the child begins to void, the alarm will ring. The child will wake up, go to the washroom and void. So that is bed and alarm technique, a sort of conditioning reflex. Third line of management is drugs. So drugs may you can use oral desmopressin. Okay, oral desmopressin can be used, or imipramine can be used, anticholinergics can be used, and so on. But they are only third line of management used for a small time, short time. So coming back to our question, it appears to be a case of nocturnal enuresis. So behavioral and lifestyle modification is the first line of treatment. We are not going to start drugs immediately. Okay. So moving ahead. So this we already covered. Vitamin A is given at birth to prevent. So what do we want to prevent with vitamin K? Yes, waiting for your answers. Yes, waiting for your answers. Yes. So I can see all of you answering correctly. It is hemorrhagic disease of newborn. Okay, hemorrhagic disease of newborn. Because we know vitamin K is required for the synthesis of clotting factors, which ones? 2, 7, 9 and 10. So obviously hemorrhagic disease of newborn is prevented because we know breast milk has got less vitamin K. So we must give 1 milligram intramuscular vitamin K to all babies at birth. It is a standard of care to prevent hemorrhagic disease of newborn. It is also called vitamin K deficiency bleeding, VKDB. So we must know the composition of breast milk and the salient differences between breast milk and cow's milk, because we get many questions related to this, like this one. So which one has got more carbohydrate, breast milk or cow's milk? So breast milk has more carbohydrate. So the lactose content of breast milk is 7 gram per dl versus 4.5 gram per dl in cow's milk. So breast milk provides more energy as carbohydrates. What about proteins? Which has got more proteins, lesser proteins? Yes. So breast milk has got lesser proteins as compared to cow's milk. So breast milk protein content is 1 gram per dl versus 3 to 3.5 gram per dl in cow's milk. So lesser protein in breast milk, so less load on immature neonatal kidneys. What else? So the proteins present in breast milk are mainly whey proteins, like lactalbumin, which are easier to digest. And breast milk contains adequate amount of amino acids like cysteine, taurine, methionine. So adequate amounts of amino acids like cysteine, taurine, methionine required for the CNS development of the baby. Okay. What about cow's milk? So cow's milk mainly has casein, which is not easier to digest, okay, which is difficult to digest by the baby. Okay, so not very good, right? Okay, yes, we need to remember some of the values and at least the relative values, that carbohydrate is more in breast milk, Protein is less in breast milk as compared to cow's milk. Which type of protein is there and all that, okay? So lipids, breast milk is richer in, so breast milk is richer in PUFA. What is PUFA? Polyunsaturated fatty acids. And DHA, that is docosahexaenoic acid, okay, which are required for the CNS development of the baby, okay. So breast milk minerals, okay. So breast milk minerals is, so calcium phosphate ratio in breast milk is such that it favors calcium absorption, okay. While cow's milk is richer in phosphate. Cow's milk is richer in phosphate. So if a baby is predominantly cow milk fed, what will happen? The baby has more chances of hypocalcemia, okay. Now remember, both breast milk and cow's milk are poor in iron, but the iron present in breast milk is more easily absorbable. More easily absorbable, okay. What about vitamins? So very important question comes directly, indirectly, yes. So breast milk contains adequate amounts of all vitamins except, yes, except which ones? Vitamin D and vitamin K and vitamin B12 in strictly vegan mothers who don't even take cow's milk, right? So because vitamin D is deficient in breast milk, it is recommended all babies should receive 400 international units per day of vitamin D throughout first year of life. Okay, it is a standard of care now. And because vitamin K is deficient, we saw that 1 milligram intramuscularly given to all babies at birth to prevent hemorrhagic disease of newborn, right? Absolute contraindication to breastfeeding. So we know breastfeeding is something which is absolutely should be given to all babies, right? So, you know a little bit about breastfeeding. Breastfeeding should begin or should be initiated within first hour of life, irrespective of whether it is vaginal delivery or cesarean section. And you know, exclusive breastfeeding we know is recommended till, so waiting for your answers, exclusive breastfeeding is recommended for the first 6 months of life. After that, what is initiated? So after that, we initiate complementary feeding. Okay, there are very few handful of conditions in which breastfeeding is contraindicated. Okay, so what is the question asking is an absolute contraindication to breastfeeding. So before answering this question, let us discuss a little bit about contraindications of breastfeeding and we come back to answer this question. Okay, so contraindications to breastfeeding. So there are some contraindications related to the baby, some contraindications related to the mother. So related to the baby, okay, and these are absolute contraindications. Related to the baby, if the baby is a confirmed case of galactosemia. What is the problem in galactosemia? So we know breast milk has got lactose. Lactose is a disaccharide that breaks down to glucose and galactose. So in galactosemia, the baby is not able to digest galactose. So baby will have jaundice, hepatosplenomegaly, cataracts, diarrhea, vomiting if the baby takes breast milk. Okay. So confirmed galactosemia or confirmed lactose intolerance, then we avoid breastfeeding. Related to the mother, there are again some absolute contraindications and some relative contraindications. Absolute contraindications are when the mother is on chemotherapy or radiotherapy. Chemotherapy or radiotherapy. Okay. And relative contraindications are some infective conditions in the mother like maternal HIV. So in maternal HIV, you know, if there is adequate safe source of, you know, some other feeding which is available, then you will give that, you can give that. But otherwise, if you do not have a safe, sustainable method of alternate way of feeding, then you must continue breastfeeding. So maternal HIV is a relative contraindication. Similarly, maternal TB, if the ATT has not been started, you avoid. But if ATT has been started for at least 3 weeks, you can give, right? So similarly, you know, if the mother has breast abscess, then that side breast you might avoid breastfeeding. If the mother has varicella lesions or herpes lesions involving the nipple area, you may avoid breastfeeding, okay, involving breast and nipple, right? So these are some of the relative contraindications where you may or may not breastfeed depending on the exact situation. You cannot generalize it for all, okay? So absolute contraindication to breastfeeding out of the given options, of course, is galactosemia in the infant. Maternal hepatitis C, CMV is not a contraindication. Herpes not involving the breast again is not a contraindication, okay? Yes, fit medico is telling secondary lactose intolerance we give. Yes, secondary lactose intolerance you can give, but primary lactose intolerance, which is a very, very rare condition, we avoid it. But confirmed case of galactosemia, we definitely, it is an absolute contraindication. Okay, confirmed case of galactosemia, right? So absolute contraindication, active TB, somebody is asking. So active TB, again, you know, TB per se is not going to get transmitted through the breast milk. You can give express breast milk to the baby even at that time. But only, you know, if the mother is directly breastfeeding, when the mother has active TB while breastfeeding, she is coughing, she can pass on the tubercle bacilli to the baby. So it is a relative contraindication. And suppose for TB you have started treatment for more than 3-4 weeks, then you can breastfeed, okay? So express breast milk can be stored for. This also sometimes comes as a question. So it depends at the temperature at which you are storing the breast milk. So at room temperature, in a country like India, we can store it for around 8 to 10 hours. Okay. In a refrigerator, you can store it even for 24 hours. And in a deep freezer, you can even store it for 3 months. So deep freezer minus 20 degrees Celsius, you can even store it for 3 months. So nowadays you have human milk banks available where they deep freeze the milk and store it for a long time. So Suya is telling if both vitamin D and vitamin K are given, and if you have to mark one, then go with vitamin K. But ideally you will not get such a controversial question. So vitamin D and K both are deficient. If you have to choose one, then go with vitamin K. Okay, right. And prophylaxis, Tanya is asking, so if the mother has TB, you know, isoniazid prophylaxis is recommended for the newborn baby. So if a mother has TB, what will you do? So let me write it here for you. So if the mother has TB, then what do? You work up the newborn for TB. That means you will do the GA for CB, GA CB-NAT for TB. You will do the chest X-ray. If the baby is found to have TB, then you start ATT. If the baby is found to have no TB, then you start isoniazid prophylaxis for 6 months. Isoniazid prophylaxis. Okay, right? All are true about human colostrum except. So let us discuss a little bit about colostrum, then we come back to answer this question. Okay. So Bhavna is asking about torch. Okay, so we'll be discussing a little bit about it. Okay, when we discuss the infectious diseases. So colostrum is the first milk that comes. Okay, the milk that comes in the first 72 hours is called colostrum after birth. Okay, it is thick, yellowish, rich in immunoglobulins like IgA, and it has a lot of macrophages also. So it helps boost the immunity of the baby. It is in fact called the first immunization of the baby, because you are supposed to, you know, start breastfeeding within first hour of birth. So it is called the first immunization of the baby. It is high in fat, minerals, vitamins, but it has low lactose. So it is not very tasty for the baby, but it is very, very beneficial for the baby, right? Then for the next 2 weeks, transitional milk comes, and finally the mature milk comes. Okay. So all are true about human colostrum except is the question. Thick and yellow color. So don't forget to see the word except. Okay. Don't jump and answer thick and yellow color as the right answer. Colostrum, thick and yellow color, move ahead. No. Please, however sure you are about the answer, please read all the options before you answer, because you will realize that thick and yellow color is right, IgA high is also right, and then you will go back and see, oh, मैंने तो accept ही नहीं पढ़ा था question में, right? Don't do that. So thick and yellow color? Okay. IgA high, yes. High amino acids and minerals, yes. High sugar, no. So, our best answer is option D here. Okay. So, there is also something called foremilk and hind milk. Let me tell you. So, foremilk is more watery. So, foremilk and colostrum are different. Colostrum is the milk that comes in the first 72 hours of life. Foremilk is the milk that comes at the beginning of every feeding session. Even if the baby is 1 month old, whenever the baby starts breastfeeding session, the first milk that comes out is thin and watery. And it satisfies mainly the thirst of the baby. But the milk that comes at the end of a feeding session, any feeding session, the milk that comes at the end is the hind milk, okay? And that is very thick and rich in fat, and that satisfies the hunger of the baby, okay? H for H, hind milk, hunger, okay? So, don't confuse between colostrum and foremilk, hind milk, okay? Right? Transitional milk, as I told you, first 72 hours colostrum, next 2 weeks transitional milk, after that mature milk, okay? So, mature milk has got higher lactose, lesser proteins, okay? So, mature milk has higher lactose, okay, and lesser protein, right? Moving ahead. So, pearly white lesions with foamy appearance seen on sclera of a child. Which of the following other symptoms are related to the deficiency of same micronutrient causing the mentioned lesion? So, nowadays we will get a lot of questions on micronutrient deficiencies as well, right? So, here we are talking about the pearly white lesions that we are talking about are, so if this is the eye, so the pearly white lesions are somewhat like this, triangular in shape and in the sclera like this. So, they are called what? Bitot spots. So, they are called the bitot spots. And bitot spots we know are features of what? So, they are features of vitamin A deficiency. And vitamin A deficiency also causes, yes, vitamin A deficiency also causes conjunctival xerosis. So, the earliest symptom of vitamin A deficiency is night blindness. So, symptom is the complaint with which the patient comes, and sign is the clinical feature that you elicit on examination. So, earliest symptom is night blindness, earliest sign is conjunctival xerosis. And we know there are other signs of all the WHO grading of vitamin A deficiency you must have discussed in ophthalmology, PSM, everywhere. So, you have after conjunctival xerosis, you have corneal xerosis, you have bitot spots, you have corneal ulceration, ultimately corneal scarring, right? Okay. Thiamine deficiency causes what? So, thiamine is vitamin B1. We know thiamine deficiency causes beriberi. Beriberi can be wet beriberi, which is more common in children where you have features of heart failure. So, there is edema, respiratory distress, intake of polished rice is associated with beriberi, right? And dry beriberi, you have neurological features. Riboflavin or vitamin B2 deficiency. Riboflavin deficiency causes angular cheilitis, stomatitis or oral ulcers, okay, aphthous ulcers, glossitis can also be there. So, mainly oral cavity is involved, okay, right. Niacin deficiency causes, yes, what does niacin deficiency cause? So, it is a very cross-cutting topic you must have discussed in biochemistry, in PSM, right. So, niacin deficiency causes pellagra. Pellagra we know is a disease of 4 Ds. What happens? Very good. So, diarrhea, dermatitis, dementia and even death can happen. So, very severe disease can be there, okay. And the necklace like rash, the Casals necklace is the typical rash that is seen, which is photosensitive. Pyridoxine deficiency again causes neurological features. So, it can cause neurological features like peripheral neuropathy, and it is a very important cause of refractory neonatal or infantile seizures. Can you name a drug that can lead to pyridoxine deficiency? So, refractory neonatal or infantile seizures. So, INH, isoniazide can predispose to pyridoxine deficiency, and that is the reason that whenever a child is on or an adult is on anti-tuberculosis drugs, we also give pyridoxine supplementation along with it, right? Very good. Cobalamin deficiency, I can already see answers. So, cobalamin deficiency can cause megaloblastic anemia, and it can also cause subacute combined degeneration of spinal cord. So, some neurological features. Okay, right. Biotin deficiency causes skin and hair involvement along with neurological features. So, biotin deficiency causes developmental delay, seizures, alopecia, skin rashes. So, if you are getting a case scenario where you are getting these features, think of biotin deficiency, right. So, biotin, again, if we get a history of raw egg consumption, raw egg has got avidin that binds with biotin and does not let it get absorbed. So, features of biotin deficiency can come. So, history of raw egg consumption can be there in the case scenario. Okay. Zinc deficiency we know causes features of acrodermatitis enteropathica. Acrodermatitis enteropathica, that means rashes around the orifices, that means around the oral cavity, around the anal region, around the genitalia, and there is diarrhea, hypogonadism, recurrent infections and so on. Okay? Yes? Right. So, moving ahead. So, coming back to our question, conjunctival xerosis we saw is a feature of vitamin A deficiency. Angular stomatitis would be there in riboflavin deficiency. Glossitis also in riboflavin deficiency. Photosensitive rash will be there in pellagra. Okay. And of course, zinc is used in the treatment of diarrhea as rightly said. Right. Yes. So, somebody is asking breastfeeding is safe while mother is hypothyroidism, hyperthyroidism. Yes, it is absolutely safe. Okay, unless of course you are doing some radioactive intervention and all. So, otherwise, you know, breastfeeding as such is safe. Okay. An 8-month-old child was found to have features of vitamin A deficiency. What is the dose of oral vitamin A required? So, dose of vitamin A is important. So, we know if the child's age is less than 6 months, the dose is 50,000 international units per dose. 6 months to 1 year, it is 1 lakh international units per dose. More than 1 year and the weight of the child, if it is more than 8 kgs, only then the dose becomes 2 lakh international units per dose. And if you are giving it for treatment, you give the first dose at diagnosis, next dose at 24 hours and the third dose at 14 days. Some books say even 14 to 28 days. So, 3 doses are required if there is vitamin A deficiency. Okay. So, this is a 8-month-old child. So, we will give 1 lakh international units per dose. Okay. So, moving ahead. So, no, it is not 0714. So, we usually give it at diagnosis, 24 hours later and 2 to 4 weeks later. Okay. So, a child presents to OPD with fatigue, bone pain, swollen and bleeding gums. Physical examination reveals petechia on her skin. Which of the following can be given to treat her condition? So, all these are features of fatigue, bone pain, swollen and bleeding gums. What are they features of? So, very good. So, all these are features of scurvy. I can see Bhavna, Akil, FMGE doctor and Premi Kishore and Riya Singh. So, a lot of you answering correctly. Yes. So, of course, we are dealing with scurvy. So, scurvy we must give vitamin C supplementation. So, scurvy is a condition where due to vitamin C deficiency of course, and we know vitamin C is required for collagen synthesis. So, if there is vitamin C deficiency, there will be defective collagen synthesis. So, let us try to understand the clinical features. So, defective collagen synthesis, and we know collagen is the backbone of blood vessels, backbone of blood vessels. So, what will happen? If collagen is defective, the blood vessels are fragile. Okay, fragile blood vessels. So, blood vessels can give away easily and they can be bleeding manifestations. So, you can have gum bleeding, you can have subperiosteal hemorrhage involving the long bones, subperiosteal hemorrhage involving long bones. So, there will be pain in the limbs, and there will be so much of pain that the child will not want to move the limbs. If a child is not moving limbs, what will you think? We will think paralysis to nahi ho gaya hai. We will think of paralysis. So, but the child is not moving the limb here because of the pain. It's not paralysis. So, it is called painful pseudo paralysis of limbs. Okay. painful pseudo paralysis of limbs. Okay, right? And there can be irritability, anemia can be there, because we know vitamin C helps in iron absorption also. It helps in neurotransmitter synthesis also. Irritability, okay? There can be anemia, right? So, of course, the treatment is going to be vitamin C supplementation, right? And you can get scorbutic rosary, lot of radiological findings, right? So, scurvy we must remember. So, we have to give vitamin C deficiency. So, yes, so we say pseudo paralysis because it is not actual paralysis, and it is because of the pain that the child is not moving the limbs. So, we saw here fatigue is there, that could be because of anemia, bone pains could be due to subperiosteal hemorrhage, swollen and bleeding gums because collagen defects, so blood vessels are fragile, petechiae on skin again because of the blood vessels fragile, so this we are dealing with scurvy, no doubt about it. And remember, if a child is predominantly cow milk fed, again more chances of scurvy, predominantly cow milk fed because cow milk has got lesser vitamin C. So, predominantly cow milk fed babies, more chances of scurvy. Okay. So, Ayush is asking how to distinguish between scorbutic and rachitic rosary. So, Ayushi or Ayush, yes. So, scorbutic rosary. So, you know, rosary means there is a bead like, you know, round. So, there is some, prominence of the costochondral junction. So, scorbutic rosary is more sharp, angulated and tender or painful. While rachitic rosary, so in rickets also you get this rosary due to vitamin D deficiency. Rachitic rosary is more rounded and non-tender. Okay, so that is how you can distinguish, and of course the other features will be there. In rickets you will have frontal bossing, parietal bossing, wrist widening, bending of bones and so on. Okay. Now, moving ahead to another very important topic, that is severe acute malnutrition. Right. So, what is the mid-arm circumference for severe malnutrition? So, before I answer this question, let us discuss the diagnostic criteria of severe acute malnutrition. So, when do you call it SAM or severe acute malnutrition? So, in a child 6 months to 5 years of age, presence of one or more of. So, what are the things? So, if there is weight for height less than 70% of expected, and what is it called? It is severe wasting. So, remember it is weight for height and not weight for age. Okay? Weight for height less than 70% of expected, or mid upper arm circumference less than 11.5 centimeters, or you can write it as 115 millimeters, or symmetric bipedal edema of nutritional origin. So, a nephrotic syndrome child also has edema. But then you don't call it severe acute malnutrition. Only if you have ruled out other causes of edema and you are thinking that malnutrition is causing edema, you did not find any abnormality in the liver function test, kidney function test, albumin and so on, still you are finding edema, then you attribute it to malnutrition. So, it is symmetric bipedal edema of nutritional origin. So, if any one of this is also present, then we call it severe acute malnutrition. Okay. So, weight for height less than 70% of expected, mid upper arm circumference less than 11.5 centimeter, and for looking at the mid upper arm circumference, the health workers can use a Shakir tape. It is difficult for them to remember the cutoffs, so they have been given with a red, yellow and green zone on the Shakir's tape. So, red zone means the child has malnutrition. Okay, malnutrition, severe malnutrition. Yellow zone is borderline and green means normal nutritional status. Okay. So, if any of these are present, then we call it severe acute malnutrition, right? So, it is Shakir's tape, not Shakira's tape, Shivangi, yes? So, that was a typo probably. So, mid upper arm circumference for severe malnutrition, the cutoff is 11.5 centimeters, right? So, if it is less than 11.5 centimeters, then we call it severe acute malnutrition. A few more questions come from severe acute malnutrition, a little bit about its management, discharge criteria and failure in treatment. This also was asked recently. So, initial hospitalization, ideally for all patients with severe acute malnutrition, especially for those with either poor appetite or any complication. What are the complications? So remember the complications of severe acute malnutrition, we can remember by the mnemonic shielded. What do you mean by shielded? So S stands for sugar deficiency or hypoglycemia. So remember, for neonatal hypoglycemia, the cutoff was 45 mg per dl. But for hypoglycemia in a child with severe acute malnutrition, we call it hypoglycemia when the blood glucose is less than 54 mg per dl. Okay. H stands for hypothermia. Definition of hypothermia in a child with severe malnutrition is rectal temperature. So we take the rectal temperature here for the cutoff. So rectal temperature less than 35.5 degrees Celsius. I for infections. Okay. EL is for electrolyte imbalance. Electrolyte imbalance. DE is for dehydration. DE is for dehydration. And another D is for deficiency of micronutrients. Right. So we'll have to look for all these complications and treat them. Okay. And of course, you have to do nutritional. Yes. So most common abnormality among micronutrient, as rightly said by Irfan, is hypokalemia. Very good. Electrolyte imbalance, hypokalemia. All the other micronutrients we supplement initially, but iron is given later in the rehabilitation phase. Okay. Nutritional rehabilitation, you start with low calories and proteins and gradually build it up, gradually increase. Why gradually? So we increase gradually to prevent refeeding syndrome or nutritional recovery syndrome. To prevent refeeding syndrome or nutritional recovery syndrome, where instead of child's condition improving, it may worsen. Okay, and it is mainly due to excess of insulin that will be secreted once you give high calories and proteins. So refeeding syndrome or nutritional recovery syndrome, where the main pathophysiological factor is excess of insulin secreted, which causes hypophosphatemia, thiamine deficiency and a lot of other problems. Okay. So Akhil is asking about the length of the session. So I think after completing general pediatrics, we'll take a short break of around 5 minutes or so, 5 to 10 minutes, and then we'll be left with systemic pediatrics. So if from now, if you think, I think the session might last for another 1 or 1.5 hours. Okay, right. So discharge criteria in severe acute malnutrition. So child should, we have initial hospitalization for all the babies, especially those with medical complications or poor appetite. What is the discharge criteria? So the child should be accepting well orally. Otherwise, you discharge the child, again the child lands up in the same situation. Should have lost edema and started gaining weight. So weight gain should not be because of the edema, it should be because of the improved nutrition. So started gaining weight. All infection and micronutrient deficiencies should have been taken care of, treated. Okay, and mother should be confident of taking care of the child at home. So that is when you discharge the baby. Okay, that is when you discharge the baby from hospital. Now there was also a recent question about when do you call it treatment failure in a child with severe acute malnutrition. So we call it treatment failure if there is failure to regain appetite by day 4, failure to start losing edema by day 4, presence of edema on day 10, and if the child is not gaining 5 gram per kg per day by day 10. So that is primary failure in treatment. And secondary failure again is failure to gain at least 5 gram per kg per day for 3 consecutive days during the rehabilitation phase. And remember, iron is to be added only in the rehabilitation phase. Okay, iron is not added in the initial stabilization phase, it is added in rehabilitation phase. Okay. Right? Yes. So moving ahead, a child's height for age is less than -2 z-score. What will you call it? Will you call it wasting, normal, stunting or severe acute malnutrition? So the most important classification of malnutrition, one classification that you must know is the WHO classification of malnutrition, which is used currently. And of course, apart from that, terminologies like Kwashiorkor and marasmus. So before I answer that question, so WHO classification of malnutrition takes into account weight for height, height for age and whether edema is present or not. So weight for height, if it is between -2 to -3 z-score or between 70 to 79% of expected, we call it wasting. If it is less than -3 z-score or less than 70% of expected, as we saw in the criteria of SAM, then it is called severe wasting. Okay. Height for age, if it is between -2 to -3 z-score or between 85 to 89% of expected, we call it stunting. If it is less than -3 z-score, less than 85% of expected, it is severe stunting. Okay, right? And if in any category, if edema is present, then we add the word edematous in front of that category, edematous, right? Okay. So, coming back to our question, here the height for age is less than -2 z-score, then of course it is called stunting. And remember, decrease in height for weight indicates chronic malnutrition, but decrease in weight for height indicates acute malnutrition. Okay. Remember, if there is low nutrition for a long time, only then height is affected, but acutely it is the weight that is mainly affected. Okay. So, a 3-year-old child presents to the OPD with mother. His mother reports exclusive breastfeeding till 2 years. Is it good? Is it bad? So, exclusive breastfeeding should be done only till 6 months. It's not कि 6 months से ज़्यादा करा दिया तो और भी अच्छा है. No. So, exclusive breastfeeding till 6 months. At 6 months, you start complementary feeding and you can continue breastfeeding till 2 years. But in addition, complementary feeding must be given. Okay. So, only breast milk was given till 2 years of age, then obviously the child is going to be malnourished. On examination, malnutrition was found along with edema. What is the diagnosis? So, before coming to this, let us discuss a little bit about kwashiorkor and marasmus, and this comes from the Wellcome Trust classification. So, this classification was an older classification based on weight for age and edema present or not. If the weight for age is between 60 to 80% of expected, edema is not there, we just call it undernutrition, no specific name for this category. But if weight for age is 60 to 80% of expected and edema is present, we call it kwashiorkor. So, whenever malnutrition with edema, a special name for it is kwashiorkor. If the weight for age is less than 60% of expected but edema is absent, it is severe malnutrition, it is called marasmus. But if the weight for age is less than 60% of expected and edema is also present, then again it has features of both marasmus and kwashiorkor, it is called marasmic kwashiorkor. Yes, marasmic kwashiorkor. So, Joy, even in HIV, it is not recommended that you breastfeed for exclusive breastfeeding for 2 years. No. Okay. So, let us discuss the differences between kwashiorkor and marasmus. So, already we said the most important difference is kwashiorkor, edema is present, marasmus, edema absent. Kwashiorkor, it is mainly protein deficiency. Mainly protein deficiency along with calorie deficiency, of course, plus calorie deficiency. Marasmus, it is mainly calorie deficiency. Okay, right? So, appetite, kwashiorkor, there is poor appetite. Marasmus babies have a very good appetite. They will eat anything that you give to them. CNS involvement is present in kwashiorkor. So, the child has apathy, lethargy. So, apathy or lethargy is there. But in marasmus, there is no CNS involvement. Fatty hepatomegaly is present in kwashiorkor, not in marasmus. Skin and hair changes more common in kwashiorkor than marasmus. What are the skin changes of malnutrition? So, skin changes of malnutrition, you can have flaky paint dermatosis or crazy pavement dermatosis. So, flaky paint dermatosis. And what is the hair sign that you see in malnutrition? It is called flag sign, alternate bands of pigmented and hypopigmented hairs. So, 3 salient features of kwashiorkor, if someone asks you. So, 3 salient features of kwashiorkor are edema, poor appetite and CNS involvement. So, 3 salient features of kwashiorkor are edema, poor appetite and CNS involvement. Okay? Yes? So, moving back to our question. So, here malnutrition is there along with edema, then our diagnosis of course is kwashiorkor. Okay? So, moving ahead, a child presents to the clinic with complaints of diarrhea. Okay? He is found to have severe acute malnutrition. So, there is diarrhea, there is severe acute malnutrition and severe dehydration, but there are no features of shock. What would be the fluid of choice for this patient? Yes? So, here I can see most of you faltering. So, hold on. So, normally if any child with diarrhea has severe dehydration, and we'll be covering it in the systemic pediatrics, of course, then we will give IV fluids. Okay, we will give RL in 5% dextrose. Okay, for severe dehydration in a child who has normal nutrition. But any child with severe acute malnutrition can very easily go into fluid overload. So, in a child with severe acute malnutrition, we will avoid giving IV fluids unless the child is in shock. Only if the child is in shock, then we would have given RL in 5% dextrose. But here, the child has severe dehydration but no features of shock. So, we would want to treat the child orally. Okay? So, the best answer for this question would have been Resomal. But that is not there in the options here. So, here we will choose ORS as the best answer. What is Resomal? Resomal is rehydration solution for malnourished child. Resomal has got lower osmolarity as compared to ORS. It has got lesser sodium, more potassium and some micronutrients as well. If you do not have Resomal, you can make ORS in double dilution and add pot chlor to it to give it as Resomal. So, our best answer here would be Resomal. If not Resomal, then ORS. But if features of shock would have been there, only then our answer would have been ringalactate in 5% dextrose. Okay, got it? Right? Moving ahead, what is the amount of milk to be given to a term baby weighing 3 kgs in first 24 hours after delivery? So, we actually what we do is exclusive breastfeeding. We need not quantify and give the milk, but say if the child has respiratory distress or if the child had some other problem, not able to breastfeed directly and we have to give top feeds or we have to give katori spoon feeds, how do we decide? So, we decide based on the birth weight. So, if the birth weight is, more than 1500 grams, then what we do is we start fluids at the rate of 60 ml per kg per day. But if it is less than equal to 1500 grams, more fluid is required, we give 80 ml per kg per day. So, this is a baby weighing 3 kgs. So, in the first 24 hours, we will give 60 ml per kg per day. Okay, 60 ml per kg per day, right? And we go on increasing by 10 to 15 ml per kg per day every day, and by 1 week this fluid requirement reaches 150 ml per kg per day, and we do not increase after that. Okay, it remains 150 ml per kg per day. First 48 hours, if you have to give fluid to the baby, we will give 10% dextrose only. So, we will give no sodium, no potassium in the first 48 hours if you have to give IV fluids, if IV fluid required, and otherwise of course we are going to give breastfeeding. Okay. Moving ahead, and for calculating maintenance fluid in older children also let's discuss. So, for older children, how do you calculate maintenance fluid? Maintenance fluid in older children, so that was for neonates, but in older children if you are asked how much IV fluid to be given, so again that will depend on the weight of the child. So, first 10 kgs you will give 100 ml per kg, very good, Joy. Next 10 kgs 50 ml per kg, and for the next any number of kgs beyond 20 kgs, weight beyond 20 kgs, you add 20 ml per kg for that, right? So, for example, if the child's weight is, somebody can tell me if the child's weight is 14 kg, how much IV fluid to be given for that child? Yes, if the weight is 14 kgs, for first 10 kgs you will give 100 into 10, that is 1000. For next 4 kgs you will give 50 into 4, that is 200. So, you will give 1200 ml. So, this is called holiday cigar formula. Very good, Tanya. So, holiday cigar formula for calculating IV fluids in children, right? Okay. And as per the latest recommendations, the IV fluid of choice in children is DNS with added KCl, with added potassium. If that is not there in the option, you can go with N/2 in 5% dextrose with added potassium. Okay. Now, which of the following are not correct about A, B, C, D, E in PALS? So, A for airway is correct, B for breathing is correct, C for circulation is correct, D for, very good. So, D is for disability. So we add potassium because body has a requirement. So any child would require 3 milliequivalent sodium per day and 2 milliequivalents potassium per day. Normally the baby is getting that from the breastfeeding. Older child is getting that from the food that we eat. If the child has to be only on IV fluids, then in that IV fluids, the 3 main things that we need to give are glucose, sodium and potassium. Otherwise, the baby may have imbalance. Okay. So DNS is dextrose normal saline. It only has glucose and sodium and chloride of course, but we need to add potassium to it to fulfill the maintenance requirements. Okay. So D is for disability. So our best answer here is D. Okay. Moving ahead, a teenager female was brought to OPD with delayed puberty. Okay. So Astha, you really need not know how much potassium to add, but usually the amount of potassium to be added is 2 milliequivalent per kg per day. Okay, unless the child has of course acute kidney injury and all. So a teenager female was brought to the OPD with delayed puberty and was found to have short stature, widely spaced nipples. What is the probable karyotype? So what are we dealing with here? So this is a female who has got delayed puberty. There is short stature, widely spaced nipples. So we are of course dealing with Turner syndrome here. So in Turner syndrome we know the karyotype is 45XO. That means the total number of chromosomes is 45 instead of 46. There is a single X chromosome, no Y chromosome. Because there is no Y chromosome, Turner syndrome is always seen in females, never in males. Turner syndrome again is an example of aneuploidy. Anywhere, if the number of, so in any human, if the number of chromosomes is not an exact multiple of 23, then it is aneuploidy. So Turner syndrome is an aneuploidy. Similarly, trisomy 21, 18, 13, all these are examples of aneuploidy. So wherever the chromosomal number, total number of chromosomes, not a multiple of 23 for humans, then it will become an aneuploidy. Okay. Yes, so Suya, best fluid maintenance is DNS with added potassium. Yes. So always seen in females. What else do we need to know about Turner's? So clinical feature has already been given. So short stature is there. You can have cubitus valgus. And there will of course be primary amenorrhea, delayed puberty. Why primary amenorrhea? Because they have streak ovaries and rudimentary uterus. Streak ovaries and rudimentary uterus. So and genitalia are not well developed. Okay. The most common heart disease in Turner syndrome, most common heart disease would be bicuspid aortic valve. If that is not there in your options, the next most common is coarctation of aorta. Okay, coarctation of aorta. Right. So apart from that, normally in females, how many bar bodies are present? The number of bar bodies is number of X chromosomes minus 1. But in Turner, even though it is a female, there is a single X chromosome. So 1 minus 1 is 0. So if you are getting a female with absent bar body, think of Turner syndrome. Female with absent bar body, think of Turner syndrome. Right? What else? So Turner syndrome, apart from this, we need to know that, the intelligence is normal. So usually these individuals have normal intelligence. So, they have delayed puberty is there, short stature is there. So, puberty is abnormal, short stature is there, but intelligence is normal in them, no intellectual disability. Okay. Another syndrome which has some similarity with Turner syndrome is Noonan syndrome. Noonan syndrome also has short stature, cubitus valgus, but in Noonan syndrome there is intellectual disability. And Noonan syndrome has got so Noonan syndrome has some features similar to Turner syndrome like short stature and all, but Noonan syndrome can be seen in males as well as females. And it has a normal karyotype and there is intellectual disability. Okay, so these are the differences from Turner syndrome. Okay. And yes, Insha is right. So pulmonary stenosis is the most common congenital heart disease in Noonan syndrome. So here coming back to our question, it is Turner syndrome. So of course the karyotype is 45X. So, okay. And PTPN11 is the gene, and Noonan syndrome has got autosomal dominant inheritance. Very good guys, so proud of you, right? Identify this pedigree. So for solving any pedigree, 3 golden rules. You must have discussed in pathology also. It is a cross-cutting, genetics is a cross-cutting branch. So yes, and Webb, Neck in Noonan and Turner both. Good. So golden rules to interpret a pedigree. 3 golden rules, any pedigree you can solve. First, if all children of an affected female are affected, what is your diagnosis? About inheritance, of course. It is mitochondrial inheritance. Yes, I will give a 10-minute break for lunch for you, okay? So, just after we complete general pediatrics, I will give you a 10-minute break for lunch, okay? So, mitochondrial inheritance. If all children of an affected female are affected, it is mitochondrial inheritance, okay? And then next what? So, if you know, for an affected child, if any parent is affected, so if one of the parents are affected, if one of the parents of an affected child have the disease, what is the mode of inheritance? It is dominant inheritance. It could be autosomal, it could be sex linked, okay? And father to son transmission rules out X linked inheritance, because from the father only the Y chromosome goes to the son, never the X chromosome. So father to son transmission rules out X linked inheritance. So these are the 3 golden rules by which you can solve any pedigree, right? Okay. So moving ahead, so moving back to our question, you can see here this female is affected and all her children are affected. This. Again, this female is affected, all her children are affected. This female is affected, all her children are affected. But affected males are not passing it over. So I think this one has been an error. This was an unaffected female. Okay. So here this is an example of mitochondrial inheritance. Some examples of disorders with mitochondrial inheritance. What are the disorders with mitochondrial inheritance? Yes. So mitochondrial inheritance disorders like Kearns-Sayre syndrome, Lake disease, okay, Lake's disease, Leber's hereditary optic neuropathy, okay. Then you have MELAS, where recurrent strokes happen, lactic acidosis is there. You have MRF, yes, all fancy names, yes, okay. So, which trisomy is suggested by this? So, first tell me what is the name of this investigation? So, yes, this is a karyotype. If you look at it closely, you can see all the chromosomes have 2 copies except chromosome 18. So, chromosome 18 has 3 copies here. So, this is trisomy 18 or Edwards syndrome, right? E for E. So, trisomy 18 or Edwards syndrome we know is trisomy 18. And the salient features, clinical features that you get a rocker bottom foot. Okay, the foot is convex below like a rocking chair. So, rocker bottom foot, overlapping digits, okay, and you have microcephaly, congenital heart diseases, okay, and so on. And while you know trisomy 13 is Patau syndrome, which is more severe disorder, where you can get holoprosencephaly, okay, okay. So, after next 15 minutes or so, I will give you a break for 10 minutes, okay, and then we will again resume, right? So, yes, and it will be almost 1 hour after the break, 45 minutes to 1 hour after the break. So, holoprosencephaly, cutis aplasia, okay, and you have a lot of congenital heart diseases and other internal problems, microcephaly, polydactyly. So, these are some of the problems that you can get, right? So, I have tried to keep this session very crisp and short, and obviously we cannot discuss everything in this short session, but I am trying to discuss as many important topics as possible for you without making the session of course too long. So a young boy is brought to the clinic for developmental assessment. On examination, he has a prominent epicanthal fold, single transverse palmar crease, hypotonia, intellectual disability. So there is epicanthal fold is prominent, single transverse palmar crease also called simian crease, hypotonia, intellectual disability, flat facies, upslanting palpable fissures. Of course, the diagnosis is Down syndrome. So Down syndrome we know is trisomy 21 and it is also aneuploidy. Patau syndrome we already discussed, it is trisomy 13, Edwards syndrome trisomy 18. Fragile X syndrome is a trinucleotide repeat disorder. Trinucleotide repeat disorder, okay, where there is a increase in number of CGG repeats and it is mainly males are affected, long face and you have macroarchidism, intellectual disability in males, okay. Down syndrome is the most common chromosomal abnormality in children. The basic defect is 3 copies of chromosome 21. Most of the cases are due to trisomy 21 and the most common pathophysiological basis is maternal meiotic non-disjunction. 3% of cases are due to translocation, 1 to 2% cases due to mosaicism. This is asked sometimes. And you can see this karyotype has 3 copies of chromosome 21. So this is trisomy 21. And for antenatal screening related questions also you get from Down syndrome, what you can see is there is increased nuchal thickness more than 3 mm. It is done in the first trimester, usually around 11 to 13 weeks of gestation we do that. On the antenatal ultrasound you can see increased nuchal thickness, okay. You can see that the nuchal thickness is increased. You can get an image based question here. So behind the neck, nuchal thickness more than 3 mm, very good. Biochemical markers that you can do in the first trimester, you can do some markers like beta HCG and PAP-A. Pregnancy associated plasma protein A. Okay, so PAP-A can be done and T2 second trimester we can do. So this of course is called the dual test, and in the second trimester you do the triple test and the quadruple test. So second trimester we do the triple test and the quadruple test. Okay, triple test, 3 things often asked. What are the 3 things of triple test? So they are beta HCG, unconjugated estriol and alpha fetoprotein. And if you add inhibin to it, it becomes a quadruple test because 4 things are being tested. Both triple test, quadruple test done in the second trimester, and all these remember are screening tests for Down syndrome, right? Integrated test is a test that takes into account maternal age because more the mother's age, more is the risk of Down syndrome. First trimester dual test, second trimester quadruple test, all these together if you take into account, it becomes the integrated test, and it has been shown to be the most sensitive test for antenatal screening for Down syndrome. But of course, now we have a test even more sensitive than that. And what is that? Yes, waiting for your answers. Even more sensitive test than that for screening. Yes, waiting for your replies. Karyotype is the confirmatory test, but even more sensitive screening test is NIPS, non-invasive prenatal screening. Here what we do, we take the maternal blood and we will do sequencing of the cell-free fetal DNA in maternal blood is extracted and we see whether trisomy 21 is there in that sample or not. So this test we are able to do from maternal blood, okay. But the confirmatory test, as someone rightly said, is fetal karyotype. For fetal karyotype, of course, we need a fetal sample. Maternal sample will not work, so this is an invasive test. If we have a strong suspicion, only then we do it. So in 11 to 13 weeks, if we want to do it, we have to do chorionic villus sampling. 14 to 16 weeks, if we want to do it, we have to take the fetal sample by amniocentesis. 17 to 20 weeks, if we want to do it, we usually take a sample by chordocentesis. This is the confirmatory test for prenatal diagnosis of Down syndrome. So now there is a cakewalk. In which trimester quadruple test is done for antenatal screening of Down syndrome? Yes. So we all know quadruple test is done for Down syndrome in which trimester? Come on. So of course it is the second trimester, right? Moving ahead, a 2-year-old girl presented with a history of recurrent episodes of early morning lethargy and seizures. Early morning lethargy and seizures, think of hypoglycemia, because what happens at night, a baby is not fed as often as daytime. So any hypoglycemic disorder will be most prominent early in the morning because nighttime the baby is not fed so frequently. So on examination, the child has doll-like faces, hepatomegaly. Investigations reveal hypoglycemia, lactic acidosis, hyperlipidemia, which enzyme is deficient. So I'm sure all of you can make out the diagnosis that we are dealing with here is von Wieren's disease or type 1 glycogen storage disorder. So, of course, our best answer is glucose 6-phosphatase. Muscle phosphorylase is deficient in McArdle disease. Okay, McArdle disease, which is type 5 GSD. Glucose 6-phosphate dehydrogenase causes a hemolytic disorder. It is not a glycogen storage disorder, and hepatic phosphorylase deficiency causes HERS disease, right? Okay. So, of course, we said that this glucose, so we have among the glycogen storage disorders, we have some disorders in which mainly liver is affected, some disorders in which mainly muscles are affected. Okay, so mainly liver is affected in which disorders? So, type 1 or von-Guericke disease we already said. Okay, and then you have Anderson disease, Cori disease. So, Anderson disease, Cori disease and HERS disease. Mainly liver is affected. Mainly muscles are affected in types 2, 5 and 7. So, type 2 is Pompe disease. Pompe disease is a bit important. So, the enzyme affected is alpha glucosidase, or it is also called acid maltase. Okay. Type 5, it is McArdle disease, muscle phosphorylase is defective, and type 7 is Tarui disease, where there is phosphofructokinase deficiency. Okay. An exclusively breastfed neonate with jaundice was found to have, so breastfed neonate with jaundice found to have this finding at 2 weeks of age. Was the probable diagnosis? So, what you see here is a oil drop cataract. So, oil drop cataract in a breastfed baby with jaundice, of course, we are thinking of, yes, I can see all of you answering correctly, yes, it is galactosemia. So, galactosemia is a condition which can be caused by the deficiency of any of the 3 enzymes. One is GALT, that is galactose 1-phosphatidylidyl transferase, or galactokinase or epimerase. Deficiency of any of these can cause galactosemia. In GALT deficiency, there is accumulation of galactose 1-phosphate, which is toxic to the liver, kidney and brain. And so, you can have jaundice, you can have renal tubular manifestations, the baby can have intellectual disability, seizures. Galactokinase deficiency leads to accumulation of galactose and galactitol, which is toxic to the eye, and it causes cataract. Typically the bilateral oil dropped cataract. Okay. And in galactosemia, you will find reducing substance in urine will be positive. Reducing substance in urine will be positive. For that, you can either do a dipstick or you can do a Benedict's test, because you have non-glucose reducing substance. So, Benedict's test will be positive. Okay. And the treatment, of course, will be a lactose-free diet. So, this is one of the conditions where we already discussed that you have to stop breast milk, breastfeeding, stop milk in any form. You have to give a lactose-free diet lifelong. Regarding the other options, so alkaptonuria is homogentisic acid oxidase deficiency, will be discussing subsequently. Hereditary fructose intolerance will not manifest at 2 weeks of age. It will manifest only when you start complementary feeding, you start sugars in the diet. Only then sucrose, which has fructose, will not get digested. It will manifest. Wilson disease again is ATP7B mutation, and it is sunflower cataract which is seen. Usually you will not see clinical features at 2 weeks age. Okay. So, moving ahead to the next question, you have a child who is brought to OPD with complaint of change in color in urine after some time. Mother gives a history that dark black color on diaper. So, urine turns black on standing. Typically, so many times you've got question on this. So, the baby was few months old. Mother has been seeing that baby is otherwise normal, and the fundus examination did not reveal any abnormality. Which enzyme deficiency is present? So, here what are we dealing with? So, I can see all of you answering correctly. That's really heartening. So, of course, we are dealing with, alkaptonuria, and alkaptonuria is homogentisic acid oxidase deficiency. So, let us discuss a little bit about the phenylalanine metabolism pathway. Okay. So, we can see that the enzyme affected in alkaptonuria is homogentisic acid oxidase. So, what will happen? Polymers of homogentisic acid are going to accumulate, which is black in color. That is why urine turns black on standing, and you can get ochronosis, which are dark spots on the sclera or ear cartilage, right? Now, what happens in phenylketonuria? So, first let us complete alkaptonuria. So, there is darkening of urine in standing due to the polymers of homogentisic acid that is accumulating. So, it is homogentisic acid oxidase deficiency. So, you can see ochronosis, the dark spots on sclera and the ear cartilage. There can be arthritis and carditis as well. Now, what happens in phenylketonuria? So, phenylketonuria is also a disorder of this pathway. There is deficiency of phenylalanine hydroxylase, and we get a lot of questions on phenylketonuria. So, let us discuss this. So, if this enzyme is deficient, what will happen? Phenylalanine will not get converted to tyrosine. So, the enzyme deficient we said is phenylalanine hydroxylase. what will accumulate in the body? So excess of phenylalanine, and it will be converted to metabolites like phenylacetate and phenylpyruvate, and they will accumulate in the body. So you will have phenylalanine, phenylacetate and phenylpyruvate that will accumulate in the body. Accumulated substances can lead to a mousy or musty urine odor. Mousy or musty urine odor can be there. And excess of this phenylalanine also causes brain damage, and that is why you have spasticity, seizures and so on. Normally in our body, phenylalanine is converted to tyrosine. So normally tyrosine is not an essential amino acid. But what is happening in phenylketonuria? Phenylalanine is not getting converted to tyrosine. So in phenylketonuria, tyrosine becomes an essential amino acid. So normally it is not an essential amino acid, but it becomes an essential amino acid in phenylketonuria. Clear? Why hypopigmentation in phenylketonuria? So phenylalanine gets converted to tyrosine, tyrosine gets converted to dopa, dopa gets converted to melanin, which is a skin pigment. In phenylketonuria, tyrosine not getting formed, dopa not getting formed, melanin not getting formed. So that is why the hypopigmentation in phenylketonuria. So once you understand the disorder, it is very, very easy to remember the clinical features, right? So coming back to our question, phenylalanine hydroxylase deficiency is phenylketonuria. We already saw the clinical features, right? Then glucocerebrosidase deficiency. Glucocerebrosidase deficiency, again we know, is Gaucher disease. We will be discussing a little bit about it. Hexosaminidase deficiency is Tay-Sachs disease. In Tay-Sachs disease, in fundus, you will get a cherry red spot, okay? And there can be regression of milestones and so on, and dark color of urine will not be there, okay? So, moving ahead. So, for the Gaucher disease, so this is for Gaucher disease, what happens? So, Gaucher disease we know is deficiency of glucocerebrosidase, glucocerebrosidase deficiency. So, what will be the clinical features for Gaucher disease? So, there will be splenohepatomegaly. The Gaucher cells are the cells with this crumpled tissue paper appearance of the cytoplasm. These are the Gaucher cells. You can get the image based question, okay? These Gaucher cells are going to accumulate everywhere in the body, especially in the reticuloendothelial system. So, there will be huge enlargement of spleen, massive splenomegaly. Hepatomegaly can also be there. Gaucher cells infiltrate in the bone marrow. They cause pancytopenia. So, because of anemia, easy fatigability, leukopenia, recurrent infections, thrombocytopenia, bleeding, bone pains and pathological fractures and neurological involvement may or may not be there. How do you diagnose it? By the clinical features, bone marrow aspiration will show Gaucher cells and you can demonstrate the enzyme activity, or genetic diagnosis can be done. X-ray of long bones can also show lytic lesions, which are called Erlenmeyer flask deformity. And for Gaucher disease, we have a very important treatment available, that is enzyme replacement therapy. So this can come as a potential question for you. So enzyme replacement therapy is available for which all disorders? Gaucher disease it is available. Among the glycogen storage disorders, it is available for Pompe disease or type 2 GSD, making it very important. Among the mucopolysaccharidosis, it is available for types 1, 2 and 6, that is Hurler, Hunter and Marotex-Lamy. And it is also available for Fabry disease, which is alpha-galactosidase deficiency. Recently, it has become available for Niemann-Pick disease, which is sphingomyelinase deficiency. So Niemann-Pick disease, again you have cherry red spot is there. Cherry red spot is there, and there is hepatosplenomegaly. There are also pulmonary infiltrates, okay? Moving ahead, a child presented with palpable rash on limbs, hematuria and joint pain. There was a history of respiratory infection 1 week ago. What is the probable diagnosis? Yes, waiting for your answers. In the meantime, let us discuss about the options. Yes. So, of course, Henoch-Schönlein purpura is one of the options here. What is the diagnostic criteria? So, it is palpable purpura is a must. You can see the palpable purpura mainly on the limbs, palpable purpura with at least one out of the following 4 things, 2 clinical, 2 lab parameters. The 4 things are, there can be abdominal pain, joint involvement in the form of either arthritis or arthralgia, and the 2 lab things, any renal involvement. So, there could be proteinuria, there could be hematuria, okay, any renal involvement can be there, okay, and any biopsy showing IgA deposition. It could be skin biopsy, it could be kidney biopsy, any biopsy showing IgA deposition. So, palpable purpura with any one out of the 4 things, we call it Henoch-Schönlein purpura. So, Henoch-Schönlein purpura, most of the cases are self-limiting. Glomerulonephritis is seen in 1/3 cases. So, very important to follow up these patients. Thrombocytopenia is absent. So even though it is purpura, thrombocytopenia is absent because here the rashes are because of the vasculitis, not because of thrombocytopenia. So thrombocytopenia is absent. Mild disease, then supportive care only, hydration, maintain nutrition, give analgesia. But significant GI involvement or other life-threatening manifestations like GI bleed, severe abdominal pain, you need to give steroids. And in severe disease, you can also resort to IVIG or plasma therapy, plasma exchange, okay. Another disease where we use IVIG, of course, is the Kawasaki disease. Kawasaki disease, we know the diagnostic criteria. It is fever for more than 5 days with any 4 out of 5 cream features, okay, with any 4 out of 5 cream features. What are cream features? So C is for conjunctivitis, which is usually non-purulent conjunctivitis. Rash is, R is for the rash on the trunk, E is for edema and erythema of extremities, A is for adenopathy or lymphadenopathy, and M is for mucosal involvement in the form of strawberry tongue. And the drug of choice for Kawasaki disease, of course, is IVIG. And you know, a dreaded complication for Kawasaki disease is obviously coronary artery aneurysm. If coronary artery aneurysm is there, you have to resort to aspirin prophylaxis for long term, and if giant aneurysms are there, even clopidogrel may be required, dual drug prophylaxis, okay. So coming back to the question, you have this palpable purpura that is there, you have evidence of kidney involvement, you have joint pain. So of course, Hinox-Schönlein purpura is a clinical diagnosis. So it is Hinox-Schönlein purpura. Rheumatoid arthritis, you need to have arthritis for at least 6 weeks, right? That is not mentioned here, and these palpable rashes might not be there. Hemolytic uremic syndrome is a triad. What are the 3 things in hemolytic uremic syndrome? Yes, can somebody tell me? So it is microangiopathic hemolytic anemia. And what do you get on peripheral smear? Yes, what do you get on peripheral smear in HUS? I am waiting for your answers. Meanwhile, I will tell you what else is there. So there is thrombocytopenia, and there is acute kidney injury or renal involvement. Yes, acute kidney injury or renal involvement. Yes, if there are giant coronary artery aneurysms, you need to give it for long term. You have to keep monitoring the baby. If the aneurysms are continuing, aspirin has to be given lifelong. If it subsides or improves, you may stop it. Okay. So yes, peripheral smear in hemolytic uremic syndrome, I need the answer. Peripheral smear in hemolytic uremic syndrome shows what? So it is a chocolate question. Yes, peripheral smear in hemolytic uremic syndrome shows what? Meanwhile, reactive arthritis will happen where there is joint involvement a few, days to weeks after an infection, which can be due to Yersinia, GI infection or any other viral infection. So nobody has answered chocolate to me here then. So it is cystocytes, broken RBCs, helmet cells, cystocytes are present in peripheral smear in HUS. Okay, not sickle cell. Right. Moving ahead, a 5-year-old child develops fever with rash. Okay, she also has cough, conjunctivitis, coryza. Fever with rash, erythematous rash, and cough, coryza, conjunctivitis. Our diagnosis becomes yes. So Insha finally mentioned helmet cells. So please eat a chocolate from my side. So yes, of course, our diagnosis here is measles. How do you distinguish it from chickenpox, erythema infectiosum, hand, foot, mouth disease? Let us see. So measles, what happens is, measles, there will be a erythematous maculopapular rash. So erythematous maculopapular rash, which is confluent at places. Maculopapular rash will be there, plus, you can have coryza, conjunctivitis, okay, coryza or conjunctivitis, right? And measles, what happens? Of course, the measles virus is there. You have Warden-Finkeldy giant cells. You can see Koplik spots can be present in the buccal mucosa. Okay, Koplik spots. Okay, right. Now, chickenpox, what happens? You have a pleomorphic rash. Pleomorphic rash. That means different type of rash at the same time. Multiple types of rash at the same time. So, you can have macules, papules, vesicles, ulcers, pustules, and crusted lesions. Multiple types of rash at the same time. Think of chickenpox, along with, of course, fever. Erythema infectiosum, slapped cheek appearance of rash. Slapped cheek-like rash with high fever, and of course the causative we know is parvovirus. Hand, foot, mouth disease, enteroviruses cause it, mainly the Coxsackie virus, and you have vesicles and blisters on palms, soles, limbs, okay, on palms, soles and limbs, and oral ulcers, okay. And measles, a long-term complication of measles is, yes, what is it? SSP, or subacute sclerosing panencephalitis, right? And measles, of course, in the treatment of measles, we also give vitamin A because it helps in better or earlier epithelial healing, decreases the chances of infection. Most common complication of measles is otitis media, and pneumonia can also happen because after measles there is decreased cell-mediated immunity. So chickenpox, we already seen, erythema infectiosum, parvovirus, B19, hand, foot, mouth disease will not be this generalized erythematous rash. So this is what you see in hand, foot, mouth disease. You can see these blisters that are there around the oral cavity, oral ulcers can be there, and palms and soles have this rash, and it is caused by enteroviruses and it spreads. It is a contagious disease. Okay. A 5-year-old child has taken 10 iron tablets with nausea, abdominal pain. What is the antidote of iron poisoning? So, of course, in iron poisoning, we will use chelating agents. And iron chelating drugs, what are the iron chelating drugs that you know of? And what is the disease in which we usually use them? So, iron chelating drugs usually we use in thalassemia. Thalassemia major, where the child is on multiple blood transfusions, what happens is iron overload. We use iron chelating agents like desferrioxamine, deferriprone and deferasirox. Out of these, deferriprone and deferasirox can be given orally, deferasirox, but desferrioxamine has to be given parenterally only. So this is the iron chelating agent of choice in iron toxicity. So desferrioxamine is the best answer as answered by most of you. Penicillamine, British anti-leucite, ADTA are other chelating agents but not helpful in iron toxicity. Penicillamine out of these is used in Wilson disease. Okay. What is the probable diagnosis? In this unimmunized child who presented with sore throat, was found to have bull neck, greyish area in the tonsillar region on examination. So this is an unimmunized child and there is sore throat, fever may or may not be there, there is this bull neck you can see here and the greyish area in tonsillar region. Of course, our diagnosis here becomes yes. So it is not mumps, it is bull neck, and this greyish area in the tonsillar region gives you the diagnosis. Sore throat and greyish area in tonsillar region, it has to be diphtheria. Mumps would not have this tonsillar patch and all, okay. Sternocleidomastoid spasm, again this swelling would not be there, okay, and tetanus again would present more with spasticity, sardonic grin, stiffness of limbs and so on. So a little bit about diphtheria. So diphtheria, the treatment of diphtheria, of course the clinical presentation we discussed, sore throat, unimmunized child, patch on tonsil, you think of diphtheria. Fever may not be there or may be there. So 50% cases fever is there. The main treatment of course is supportive and the drug of choice is antidiphtheritic serum. And of course, you also need to give antibiotics like penicillin, erythromycin, clindamycin, rifampicin, tetracycline to halt the further toxin production and to treat the localized infection and to reduce transmission. Okay. Now, what is also important asked many a times is what do you do with the contacts of a case with diphtheria? Diphtheria is a very, very infectious illness. So, all household contacts of a case need to be isolated and monitored because they can also spread infection to others. Okay. They can themselves get infected and can spread infection to others. And cultures to be sent if any lesions appearing in the contact. So, we are talking about contacts. So, we already talked about the treatment of an affected case, now about the contacts. So, chemoprophylaxis should be given to all close contacts of the patient irrespective of the immunization status. Even if they are immunized against diphtheria, still the contacts need to be given prophylaxis. It could be single dose injection benzathine, penicillin or erythromycin for 10 days or single dose azithromycin. Vaccination is recommended to be given to all individuals who have not received a booster in last 5 years whenever they are coming in contact with a case of diphtheria. So, vaccination of contacts we are talking about. If less than 7 years, you will give DPT. If more than 7 years, you will use Tdap. And all children who have received less than 4 doses of diphtheria containing vaccine should be immunized, right? So, what are the complications of diphtheria? Why are we so worried? So, cardiac involvement, there can be toxic cardiomyopathy. The first indication of toxic cardiomyopathy would be a disproportionate tachycardia. Okay. So, even more than the degree of fever can cause the tachycardia is there. Neurological, there can be paralysis of soft palate, involvement of multiple nerves. You can have nasal intonation of voice, nasal regurgitation of feed can be there, and you can have oculomotor and ciliary paralysis, and there can be even quadriparesis of all limbs. Okay. So, that can be there. Yes, break coming up in 5-10 minutes. Which of the following vaccines is recommended at birth? Waiting for your answers. So, vaccines given at birth, let's quickly summarize the national immunization schedule. The birth vaccines are BCG, OPV 0 dose, hepatitis B birth dose. 6 weeks, 5 vaccines to be given. What are they? So, OPV 1, Rota 1, Penta 1, FIPV 1, PCV 1. 10 weeks, 3 vaccines, OPV 2, Rota 2, Penta 2. 14 weeks, again same as 6 weeks, 5 vaccines to be given. 9 to 12 months, you give MR1, PCV booster, FIPV3 has been recently added, and in endemic areas, Japanese encephalitis. 16 to 24 months, MR2, DPT1, DPT booster 1 and OPV booster and Japanese encephalitis second dose. 5 to 6 years, DPT booster 2, 10 years and 16 years, TD instead of TT, right? So, coming back to our question, which of the following vaccines is recommended at birth? Measles vaccine, no, it is recommended at 9 months, and measles vaccine is given subcutaneously. Japanese encephalitis vaccine is given only in endemic areas, again at 9 months and 16 to 24 months. If it is a live vaccine, subcutaneously, killed vaccine intramuscularly. BCG vaccine is given at birth, and it is, what is the route of administration of BCG vaccine? It is intradermal. What is the site? So, it is given at the left upper arm, okay? And so intradermal left upper arm BCG vaccine, and it is a live attenuated vaccine. And it is in an amber colored vial because, it is light sensitive also. DPT vaccine, again not given at birth. It is a part of the pentavalent vaccine. So, the pentavalent vaccine in the national immunization schedule, obviously penta means 5, it protects against 5 diseases. What are they? So, pentavalent vaccine protects against 5 diseases. What are they? So, it protects against diphtheria, pertussis, tetanus, hepatitis B and Haemophilus influenzae. Okay, so these are the 5 diseases against which the pentavalent vaccine protects. And yes, vitamin A is given at 9 months, even though it is not a vaccine, it is usually clubbed with the immunization schedule. So, 2 open vials of pentavalent vaccine and 1 open vial of MMR vaccine is given back after an immunization session. What should be done with those? Both have to be discarded, one of them can be used, both can be reused. So, this is a question on open vial policy. So, I will wait for your answers. Meanwhile, let us discuss open vial policy. So, open vial policy basically allows reuse of partially used multi-dose vials. Of vaccines. So, suppose one vaccine vial has 10 doses, only 3 children came for immunization. What will you do with the rest of the 7 doses? So, if the vaccine follows open vial policy, you can reuse it in the next immunization session. If it does not follow open vial policy, you have to discard it. So, it allows the reuse of partially used multi-dose vials of certain vaccines up to 4 weeks of opening, okay, provided certain conditions are met. What are they? So, the label should be intact and readable. VVM, the vaccine vial monitor, should show that the vaccine is usable. Expiry date of the vaccine should not have passed. Vaccine should not have been frozen. And septum is not leaking. Date and time of opening is mentioned. So, if all these conditions are fulfilled, you can reuse certain vaccine vials. So, what are the vaccines which follow open vial policy? So, remember 2 vaccines which do not follow open vial policy. So, vaccines which do not follow open vial policy is easier to remember, that do not follow open vial policy. The important ones are, yes, so T series vaccines of course follow open vial policy. The ones that do not follow are BCG does not follow, MR does not follow. The main 2 vaccines that do not follow open vial policy are BCG and MR or MMR or any measles containing vaccine, okay. And vaccine vial monitor, you get questions. VVM, of course, we know the full form is vaccine vial monitor. If an image based question is there, when can you use, when you cannot use the vaccine. If the inner square is lighter than the outer circle, you can use the vaccine. If it is same or darker than the outer circle, you cannot use the vaccine. So, coming back to our question. So, pentavalent vaccine is a T series vaccine. It follows open vial policy. But MMR vaccine, we know, does not follow open vial policy. So, our best answer here is pentavalent can be used in subsequent session, but MMR must be discarded. So, B is the best answer here. Yes? Okay. So, here we take a break as promised, a break for 10 minutes for you to have lunch. Please quickly go and have lunch. So, break for 10 minutes for all of you, and then we will resume with the remaining topics from systemic pediatrics. So, it is 2:35 now. So, we start again at 3:35 p.m. Okay, we start again at 3:35 p.m. A 10-minute well-deserved break for all of you, right? See you in 10 minutes. Hello dear students, welcome back. So I hope if not lunch you had a cup of tea or coffee. I'm still having mine though. So let us start with the remaining topics of systemic pediatrics. Yes, please confirm if I am audible and if my screen is visible so that we can start. Thank you, Insha. Okay. Thanks, Gudara, Tanya. Yeah. So a 5-year-old child. So a 5-year-old child presents with exertional dyspnea. So I'm trying my best to answer all the questions that I'm getting in the chat box. But if I am not able to answer any of them, please feel free to message me on Instagram or here or on any of the social media handles. I'll definitely try to get back. Okay. So a 5-year-old child presents with exertional dyspnea and a history of cyanotic spells. Okay. On examination, there is clubbing and a harsh systolic murmur is heard at the left upper sternal border. Okay, harsh systolic murmur. Chest X-ray shown below. What is the most likely diagnosis? So, of course, you can appreciate this boot-shaped heart that is there. So, I can see, yes. So, I can see most of you answering correctly. It is, of course, tetralogy of Fallot, right? Let us discuss a little bit about tetralogy of Fallot. So, what are the components of tetralogy of Fallot? So, there is a large ventricular septal defect, pulmonary infundibular stenosis, overriding of aorta and right ventricular hypertrophy. So, tetralogy of Fallot, so there has to be 4 components. So, you can see ASD is not a component, okay. ASD is not a component of tetralogy of Fallot. It is large VSD, pulmonary infundibular stenosis, overriding of aorta and right ventricular hypertrophy, okay. So, what are the clinical features of tetralogy of Fallot? So, in tetralogy of Fallot, you know, even though there is a VSD, large VSD, there is no murmur because of VSD, no VSD murmur. Because the VSD is so large that both the left and right ventricles are acting almost like a single chamber. So, there is no pressure gradient that is existing. However, the auscultatory finding you get in tetralogy of Fallot is because of this pulmonary stenosis. So, you get a ejection systolic murmur in the pulmonary area. And what else? You get a single second heart sound. Single second heart sound, why? Because the P2 is soft and inaudible. Okay, P2 soft and inaudible because aorta is coming in front of the pulmonary artery. Okay, P2 is soft and inaudible. Right? Okay. So that is the auscultatory finding. The clinical features, of course, you will have, so there will be cyanosis. Why cyanosis? Because of the pulmonary stenosis, lesser blood is going to the lungs, lesser blood is getting oxygenated, so there is hypoxia. Long-standing hypoxia will lead to cyanosis as well as clubbing. You can appreciate the clubbing you see here, right? You can see clubbing, you can get an image-based question like this. So cyanosis and clubbing would be there. And because the body is detecting that there is hypoxia, so body will try to compensate by producing more and more RBCs. There is polycythemia. Okay, polycythemia will be there. And there will be period of times when cyanosis will worsen, cyanotic spells can be there. Okay. And because of this polycythemia, you know, there can be complications. So, there can be complications. So, less than 2 years old child, you can have cerebral thrombosis. And more than 2 years, there can be cerebral abscess. Okay. Right. So, coming back to the X-ray. So, there is this boot-shaped heart because the apex is formed by the right ventricle. And there is also pulmonary oligemia. Because of lesser blood going to the lungs, you can see that the bronchovascular markings are not very prominent. So, there is pulmonary oligemia, right? What about TAPVC, total anomalous pulmonary venous connection? What happens? So, TAPVC, the basic defect is normally the pulmonary veins we know drain into the left atrium. But in TAPVC, the pulmonary veins, instead of draining in the left atrium, they will drain in the right atrium. So, it is total anomalous pulmonary venous connection. And in supracardiac type of TAPVC, you can get a snowman or figure of 8 appearance. Snowman or figure of 8 appearance. Okay. TGA or transposition of great arteries, you get an egg on side appearance. So, here what happens? From the right ventricle, instead of pulmonary artery, aorta will come out, and from the left ventricle, instead of aorta, pulmonary vein will come out, pulmonary artery will come out. Coarctation of aorta is a narrowing in the aorta. So here, because there is cyanosis, because there is clubbing, systolic murmur in the left upper sternal border, that means pulmonary area, and the X-ray showing boot-shaped heart, our diagnosis is tetralogy of Fallot. Okay. Now moving ahead, what could be the possible diagnosis for a newborn exhibiting weak lower limb pulses and strong upper limb pulses? So weak lower limb pulses means there is some narrowing between the arch of aorta and the descending aorta. So that is why upper limbs are getting adequate blood, lower limbs getting lesser blood. So of course, if there is a narrowing, we are thinking of, very good, I can see all of you answering. So it is coarctation of aorta, right? So coarctation of aorta is the best answer here, right? So coarctation of aorta, the most common location is juxtaductal, near the ductus arteriosus, or it is at the junction of arch of aorta and descending aorta. Okay, arch of aorta and descending aorta. So that is why the pulses are normal in upper limbs, but in lower limbs they are feeble pulses. Clinical features as we said, so there will be feeble lower limb pulses, feeble or absent lower limb pulses. And then the manifestations will be depending upon the severity, okay. So if it is very severe, then in neonate or infant it can present with heart failure. So heart failure with feeble femoral pulses, think of coarctation of aorta. Moderate, then it can present only with hypertension. Why hypertension? Lesser blood going to all organs of the body, lesser blood going to the kidneys also, renin-angiotensin system getting stimulated, hypertension. And in mild cases, there can be just some intermittent claudication of lower limbs. So on exertion, there will be lower limb pain. Okay, intermittent claudication of lower limbs. Okay, right. So you can see there is notching of inferior margin of ribs. So there can be this notching of inferior margin of ribs because of the collaterals that develop between the anterior and posterior intercostal arteries. Okay. And of course, we can also get the figure of 3 appearance, okay, or E sign, okay. Why? Because there is a narrowing in the aorta and there is a pre-stenotic dilatation and a post-stenotic dilatation, okay. What do you see here? So here we can make out there is a egg on side appearance. So egg on side appearance, where do we see egg on side appearance? Yes. Egg on side appearance we see TGA or transposition of great arteries. Yes. So egg on string or egg on side appearance, you can call it TGA or transposition of great arteries. What do you see here? So here you can see there is huge cardiomegaly such that the heart is occupying almost the entire thorax. So this is box shaped heart. Box shaped heart. It is seen in, yes, it is seen in, very good Abdul. So it is seen in Epstein anomaly. So Epstein anomaly is a condition where the tricuspid valve is abnormal, structurally, functionally as well as location wise. So there is downward displacement of the tricuspid valve, atrialization of the right ventricle, and there is huge cardiomegaly. Even on ECG you can get Himalayan P waves. So you can get Himalayan P waves, huge P waves resembling peak of mountain, okay, on ECG. So a 3-year-old child with diarrhea for 2 days was irritable and extremely thirsty. What is the next step? So a 3-year-old child with diarrhea for 2 days. So diarrhea is there, the child is irritable and extremely thirsty. The next step will depend upon the degree of dehydration for this child. So let us see how to assess dehydration in a child with diarrhea. Yes. So assessment of dehydration will depend upon mainly 3 things: sensorium, thirst and skin pinch. So if the child is, well and alert, then there is no dehydration. Restless and irritable in some dehydration, and very, very lethargic and comatose. Lethargic and maybe even comatose in severe dehydration. Okay, very, very lethargic and dull. Thirst, drinks normally, not thirsty, no dehydration. Thirsty, drinks eagerly, some dehydration. Not able to drink or feed in severe dehydration. Not able to drink or feed. Okay. Skin pinch, goes back quickly, no dehydration. Goes back slowly, some dehydration. And severe dehydration goes back very slowly. Very slowly meaning taking more than 2 seconds. Okay. Mucosa of course is moist in no dehydration, dry and very dry, some and severe. Eyes normal in no dehydration and sunken in some and severe. tears normal in no dehydration, absent in some and severe. So mainly you look at sensorium, thirst and skin pinch, okay, right. So this class again, it will last for approximately 45 minutes or so, okay, maybe even less. So treatment of dehydration in a child with diarrhea. So we first classify it into no dehydration, some dehydration, severe dehydration. You have seen I have color coded the rows because IMNCI classification. So in the IMNCI classification, there is this color coding. What do you mean by IMNCI? So IMNCI is Integrated Management of Neonatal and Childhood Illnesses, where there are some algorithms given for health workers for management of common conditions. So if there is no dehydration, what is recommended is home-based care, nothing specific needs to be done. But you just need to give ORS, of course. So no dehydration, what will you do? Even if there is no dehydration, why will we give ORS? To prevent dehydration. So you give WHO ORS 5 to 10 ml per kg per loose stool. If that is not available, you can encourage home-based fluids can be taken adequately. Some dehydration, what do you do? So some dehydration, you have to prescribe WHO ORS almost 75 ml per kg over 4 hours. If the child is having a lot of vomiting, then you can prescribe the same amount as IV fluids. Severe dehydration, you have to give 100 ml per kg, okay, and this 100 ml per kg you give as IV fluid, okay, and you break it as first 30 ml per kg, next 70 ml per kg. So if the child is less than 1 year, first 30 ml per kg you give over 1 hour, next 70 ml per kg over 5 hours, so total over 6 hours. If the child is more than 1 year, you give it in half the time. So first 30 ml per kg in half an hour, next 70 ml per kg in 2.5 hours. So total time taken is 3 hours. 2.5, yes, 3 hours. Yeah. So, and you give it as IV fluid. So the fluid of choice is IV RL in 5% dextrose. But remember, dextrose alone is not given. Either you use RL in 5% dextrose or you can use normal saline with added potassium as well. Okay. Now, WHO ORS, the composition is important. We need to know that the sodium and glucose both are 75 millimoles per liter or milliosmoles per liter. And you know, potassium is 20, chloride 65, citrate 10. So making a total osmolarity of 245 milliosmoles per liter or millimoles per liter. So this is the WHO ORS. It is same as, it is also called reduced osmolarity ORS. But of course, it is different from Resomal. Okay, remember we already discussed Resomal, rehydration solution for malnourished child, which has got lesser sodium, more potassium and some micronutrients in addition. Okay. So treatment of diarrhea in children, we need to give WHO ORS or fluid replacement, we need to give zinc and we need to continue normal diet. So for acute diarrhea in children, no dietary modification is required. Okay. So coming back to our question. So this child is irritable, extremely thirsty. Which degree of dehydration it is? So we will classify it as some dehydration. And in some dehydration, what are we going to give? IV, normal saline or ringer lactate is not required. We will give oral rehydration solution. Fruit juice with added salt again is not required. Okay. And of course, we will have to give zinc therapy. So zinc therapy, if a child is between 2 months to 6 months, we give 10 mg per day. More than 6 months, we give 20 mg per day for 14 days. Okay. So that is the management of acute diarrhea in children, right? If there is persistent diarrhea, of course, you will do dietary modification. A child with diarrhea again was eager to drink and skin pinch went back slowly. So eager to drink, skin pinch went back slowly. So which category as per IMNCI if the question asks? So again, this is some dehydration, and remember we saw some dehydration was in which background? Pink, yellow or green? Yes, some dehydration is yellow. So you can get questions like this also. So in the IMNCI, two main disorders that we need to know is, one is diarrhea and the other one is pneumonia, that we will be discussing. Okay. So moving ahead, a 3-year-old child presented with recurrent episodes of diarrhea and abdominal distension. On examination, he was found to have anemia, short stature and failure to thrive. His anti-TTG IgA levels was 25 and upper GI endoscopy with duodenal biopsy reveals villus atrophy. Of course, we all know what is the diagnosis. Yes, So I can see all of you answering correctly. Very good. So it is celiac disease. Why celiac disease? There's recurrent episodes of diarrhea and abdominal distension, anemia, short stature, failure to thrive. All these are features of celiac disease. The screening test for celiac disease is anti-TTG IgA, which is elevated here. And the confirmatory test, of course, is duodenal biopsy, which shows villus atrophy. What else? Crypt hyperplasia and increased intraepithelial lymphocytes, right? So celiac disease, the recommended screening test as per the latest guidelines, recommended screening test is a combination of anti-TTG IgA and total IgA is what is usually recommended, okay. And this is also the most sensitive test for the diagnosis of celiac disease, okay. And most specific antibody for the diagnosis of celiac disease, of course, is anti-endomysial antibody, okay. And the confirmatory diagnosis usually is done by upper GI endoscopy and duodenal biopsy, which of course you've discussed in pathology will show what? So it will show villus atrophy, crypt hyperplasia and increased intraepithelial lymphocytes. And this is Marsh grading is also there for this. And the treatment, of course, is lifelong gluten-free diet. So it is also asked sometimes that which food item should the child avoid or which food item can the child eat. So we know any wheat or wheat-based products like semolina, suji, all that has to be avoided. Ideally, oats also has to be avoided. So, some sources say brow has to be avoided. So, barley, rye, oat and wheat and any wheat products should be avoided. But the child can safely take rice, corn. So, any other, gluten-free diet can be safely taken, okay. So, moving ahead, a 2-year-old child presents to a primary health center with complaint of cough and fever, okay. So, cough and fever, yes. So, Akhil is telling oat is safest. So, oat, if it is very, very pure oat without any contamination with wheat, then some sources say that you may still have it. But mostly the oats that is available has some sort of contamination with wheat. So, usually it is avoided. So, a 2-year-old child is brought to the primary health center with cough and fever. On physical examination, chest and drawing was present. Respiratory rate 38 per minute. The child was otherwise feeding well, normal sensorium. What is the best next step of management? So, before answering the question, so let us discuss a little bit about the IMNCI guidelines for a child with cough or difficulty in breathing. Then we come back to answer this. When do you call it fast breathing? In a child less than 2 months of age, we say fast breathing when the respiratory rate is more than 60 per minute. 2 to 12 months if it is more than 50 per minute. 1 to 5 years if it is more than 40 per minute. What are the general danger signs? So, general danger signs are like, so there is, if there are convulsions or seizures, okay, convulsions or seizures, lethargy, persistent vomiting, inability to feed or unconsciousness. Okay, if any of these are present, then we say general danger signs are present and the child is classified in a severe category. So, there is this again color coding of pink, yellow and green. The most severe category is always pink in IMNCI and there you have to do immediate stabilization and refer here. So, any general danger sign or stridor in a calm child, you classify it as severe pneumonia or very severe disease, okay? Severe pneumonia or very severe disease. And what will you do? So, you will give first dose antibiotics and refer. First dose antibiotics and refer. Okay. What about if there is no danger signs, no general danger signs, but there is either chest indrawing or fast breathing or both are present, then you classify it as pneumonia, okay. And what do? You start oral antibiotics. Usually amoxicillin is used, so start oral antibiotics. So, usually you will prescribe amoxicillin for 5 days and follow up after 2 to 3 days and explain danger signs and the child can be sent home. Okay, explain danger signs, the child can be sent home. Okay. And if the child has got no signs of pneumonia or severe disease, that means no general danger sign, no fast breathing, no chest indrawing. Then we classify the child as cough or cold only, or you can say no pneumonia. So you only advise home-based supportive care, and of course you will explain danger signs. So home-based supportive care. So that is about the IMNCI classification, simplified version rather of the IMNCI classification of a child with cough or difficulty in breathing. So coming back, so here what is happening? The child is having cough and fever. There is chest indrawing. So chest indrawing is present, that means the child has pneumonia. Fast breathing is there or not? So 2-year-old child respiratory rate is 38 per minute, that means less than 40 per minute. So there is no fast breathing, but there is chest indrawing, so it is pneumonia. But the child is feeding well, normal sensorium, that means no general danger sign. So it is pneumonia. So what is your diagnosis? What is your best answer? So is it severe pneumonia, start IV antibiotics? No, there are no general danger signs. Is it moderate pneumonia, treat in the clinic? So there is no terminology as moderate pneumonia in the IMNCI classification. Pneumonia, give oral antibiotic, follow up after 2 days as primary health care center is the best answer. No pneumonia, cough and cold only, no. As there is chest indrawing, we will label it as pneumonia and give antibiotics, okay. So this is also not the best answer. The best answer is option C. So once you have the concept here, you can answer any question that comes related to it, okay. So moving ahead, this question again comes multiple times in various forms. So a child with difficulty in breathing had steeple sign on X-ray. What is the treatment? So remember, steeple sign in X-ray is seen in which condition? Yes. So before answering this question, let us first discuss a little bit about croup and acute epiglottitis. Then we come back to this question. So croup is a viral illness. Okay. So etiology is virus. So most common cause in fact is para-influenza virus. Okay. Because it is a viral illness, the child is not very sick usually. So usually there is low grade fever. Stridor is there in both croup and acute epiglottitis. Stridor is there, of course. So there is low grade fever is there. Okay, low grade fever is there. There can be coryza, barking kind of cough can be there, and there can be some respiratory distress. And on X-ray you see a steeple sign, that is narrowing of the airways. Now because croup is a viral illness, no role of antibiotics in the treatment. So one of course is supportive care, that means you hospitalize the child, and if there is hypoxia you start oxygen, if lot of distress you start IV fluids for the time being. But the treatment of choice even in mild cases is single dose dexamethasone. Single dose dexamethasone. And in moderate to severe cases, in addition to single dose dexamethasone, you also give nebulized epinephrine. And we said no role of antibiotics, okay? No antibiotics in croup. What about acute epiglottitis? So acute epiglottitis is a more severe illness, okay? So acute epiglottitis is a more severe illness. So because it is a bacterial illnesses usually the baby is sicker. So the most common cause, so this again is a controversial thing, but as per the sources, so the most common cause in immunized population, as per the latest references, the most common cause in immunized population is streptococcus. In unimmunized population, it is still Haemophilus influenzae type B, okay. So what is the usual manifestation? So here high grade fever, sick or toxic looking child, okay, and there can be drooling of saliva. So the baby is having so much of distress that the child is not able to swallow his or her own saliva. On X-ray you can get what is called the thumb sign, and on laryngoscopy you can get a cherry red epiglottis, which is a congested and swollen epiglottis. And because it is a bacterial illness, what do you give? So the treatment of choice is antibiotics. So IV third generation cephalosporins like ceftriaxone is the treatment of choice, in addition to, of course, supportive care like moist oxygen, humidified oxygen, and you have IV fluids and so on, right? And this is the thumb sign that we are talking about in acute epiglottitis, the thumb sign. And you can see the steeple sign on the X-ray where there is narrowing of the airway here, steeple sign, okay? So coming back to our case scenario, of course, we are dealing with a case of croup because there is steeple sign on X-ray, and croup is a viral illness, no role of antibiotics. So treatment, antibiotic steroid oxygen, no, we do not want to give antibiotics. Maybe later on, few days later, if the child is now developed secondary bacterial infection, there might be role of antibiotics, but as such in a child with croup, no role of antibiotics. Oral steroid, yes, that can be done. Antibiotic, cough suppressant, decongestant, no. Reassure the patient only, no. So the best answer out of the given options is oral steroid. So single dose dexamethasone is the treatment of choice, okay? So the next question, the most common cause of inspiratory stridor in an infant. So the most common cause of inspiratory stridor in an infant, of course, is laryngomalacia. So parainfluenza virus infection, it's croup. Acute epiglottitis, we already saw that the baby is quite sick. Acute laryngotracheal bronchitis again is croup. So laryngomalacia is a condition where, you know, the larynx, the epiglottis has not developed properly, right? So there is omega shaped epiglottis, a loose and lax epiglottis. So omega shaped epiglottis. So the baby usually has stridor, which increases on feeding or crying, and improves in prone position due to gravity, okay? So improves in prone position, okay? And usually it is a self-limiting illness. Usually the child outgrows it, no treatment is required. On the contrary, in choanal atresia, what happens? The respiratory distress improves on crying because the baby is opening the mouth, nose is blocked, okay? The nasal pathway is blocked. So in choanal atresia, the respiratory distress will improve on crying, okay? Respiratory distress improves on crying when the mouth opens, right? Okay, a 4-year-old boy presents with recurrent sinusitis and repeated lung infections. Genetic testing showed a mutation in the CFTR gene. Which test will help in the diagnosis? Is it sweat chloride test, lung biopsy, chest x-ray, nasal swab culture? So here, of course, the CFTR gene is there, so we are suspecting a case of cystic fibrosis. Let us see the diagnostic criteria of cystic fibrosis. So you need 1 out of clinical criteria and 1 out of lab criteria. Clinical features include recurrent pneumonias, steatorrhea or fat in stool or oil in stool. So there is steatorrhea, failure to thrive, okay? And the pneumonias are usually due to Pseudomonas or Staphylococcus, or even Burkholderia cepacia is a pathognomonic organism. Family history of similar illness in a first degree relative. So in a sibling maybe, okay, in a first degree relative. Or, you know, newborn screening test positive. What is the newborn screening test for cystic fibrosis? Yes, the newborn screening test for cystic fibrosis is IRT, immunoreactive trypsinogen. Immunoreactive trypsinogen is the newborn screening test for cystic fibrosis. Lab criteria would be sweat chloride more than 60 milliequivalents per liter on 2 separate occasions. CFTR gene, so 2 or more pathogenic mutations. So CFTR is a very long gene on chromosome 7. So 2 or more pathogenic variants or mutations in the CFTR gene. So one of the mutations commonly seen in the Indian population is delta F508, okay? F is for phenylalanine, delta means deletion. So deletion such that there is an absence of a phenylalanine residue at 508 position of CFTR, okay? And nasal membrane potential difference abnormality. So 1 out of the clinical and 1 out of the lab criteria required for the diagnosis. So here, of course, CFTR gene is involved, recurrent sinusitis, repeated lung infections. So we will, of course, do a sweat chloride test, okay? Moving ahead, a newborn. So you have a newborn who presents with dehydration, shock, ambiguous genitalia. Ambiguous genitalia means you're not able to make out whether it is a male or a female. He was found to have hyperkalemia, high 17-hydroxyprogesterone, and DHEA levels. The karyotype was 46XY. Okay. So I think, okay. So the karyotype was 46XY. What is the probable diagnosis? So here there is an error with the question. So the karyotype here should have been 46XX. Okay. So 46XX. So in a female, if you are getting ambiguous genitalia, okay, and you're getting dehydration, shock, hyperkalemia, high 17-hydroxyprogesterone, then of course your diagnosis will be, yes, I'll be waiting for your answers. Before that, let us discuss the steroid pathway a little. So what happens? So we are talking here about CAH or congenital adrenal hyperplasia. Okay. So congenital adrenal hyperplasia, the most common type is due to 21-hydroxylase deficiency. What will happen in 21-hydroxylase deficiency? Let us see. So in 21-hydroxylase deficiency, you can see what is happening. So 21-hydroxylase deficiency, what is happening is, so here what is happening, the mineralocorticoid and glucocorticoid synthesis is not happening properly. Okay. So 21-hydroxylase enzyme is actually seen in the mineralocorticoid and glucocorticoid pathway, and it is not there in the sex steroid pathway. Okay. So 21-hydroxylase deficiency is seen in, 21-hydroxylase enzyme is seen in the mineralocorticoid and glucocorticoid pathway, not in the sex steroid pathway. So what is going to happen is, mineralocorticoid synthesis is not taking place properly, so aldosterone will not get synthesized. So what will happen? Sodium will not get absorbed, potassium will not get excreted. So there will be dehydration and hyperkalemia. So less mineralocorticoid, so there will be dehydration and hyperkalemia. Okay. The glucocorticoid pathway is also not taking place properly. So what will happen? So there will be less glucocorticoid. So there will be shock. Okay. And what will happen? So this pathway is stopping here. Okay. This pathway is stopping here. So there will be elevated 17-hydroxyprogesterone level. This pathway is stopping here. There will be elevated progesterone levels. And excess of metabolites will be shunted to the sex steroid pathway. Excess of testosterone will be produced. So a female will have ambiguous genitalia. So ambiguous genitalia in a female. But in a male baby, the genitalia would be a male genitalia only. There can be some hyperpigmentation. So this disorder can be easily missed in a male baby. So ambiguous genitalia in a female. So that is when we suspect 21-hydroxylase deficiency. Okay. So coming back to our question. So what happens in 21-hydroxylase deficiency? So you have ambiguous genitalia in a female, hyperkalemia, dehydration and shock, high 17-hydroxyprogesterone level, progesterone and DHEA level. So this is 21-hydroxylase deficiency. Okay. So let us summarize. So 21-hydroxylase deficiency, because of deficiency of mineralocorticoids, again try to understand, no aldosterone getting formed. Aldosterone helps in absorption of sodium and water, excretion of potassium. No aldosterone getting formed, so there will be salt wasting, dehydration. So salt wasting, okay, dehydration and hyperkalemia. Deficiency of glucocorticoids, there will be shock. Excess testosterone, so ambiguous genitalia in a female. Genitalia in female. Okay. But what will you use for treatment? So for the treatment we will give hydrocortisone to replace the glucocorticoids and fludrocortisone to replace the mineralocorticoids. Okay. Fludrocortisone to replace the mineralocorticoids. Okay. What about the other options? So in 17-hydroxylase deficiency, what will happen? So you can see this 17-hydroxylase enzyme is here. So 17-hydroxylase enzyme, what will happen is excess of mineralocorticoids will be produced. So there will be hypertension. There will not be any salt wasting or dehydration. Okay. So it is not the case here. Turner syndrome again will not present with ambiguous genitalia, And we're not thinking of septic shock because there is high 17-hydroxyprogesterone level, progesterone level is high, hyperkalemia is there, ambiguous genitalia is there. So we have enough evidence to call it congenital adrenal hyperplasia. So we are not considering septic shock here, right? So the next question, you have a 5-year-old child who presented with edema for last few months, okay? Edema for last few months, and it started on face, but now it is generalized with pedal edema as well as ascites. He showed good response to steroids. His blood sugar was 112 milligram per dl, which is normal. On urine examination, massive proteinuria was seen. On electron microscopy of kidney biopsy, effacement of podocytes was seen. Identify the given condition. So of course, this child is suffering with nephrotic syndrome, right? Because there is massive proteinuria, okay? Which type of nephrotic syndrome most common in children? We know it is minimal change disease. And in minimal change disease, in kidney biopsy, electron microscopy, you will see effacement of footplate of podocytes. So it is minimal change disease. It is the most common cause of nephrotic syndrome in children, right? Why is it called minimal change disease? Because in light microscopy, you will see it is absolutely, the kidney biopsy will be absolutely normal, no findings. Only in on electron microscopy, you can see the effacement of footplate of podocytes, okay? Now, what about the treatment of nephrotic syndrome? So, treatment of nephrotic syndrome, so if it is the initial episode nephrotic syndrome, initial episode, the drug of choice of course is prednisolone. Okay, so you give 2 milligram per kg per day for 6 weeks, daily for 6 weeks, daily, followed by 1.5 milligram per kg alternate day for 6 weeks. So for first episode nephrotic syndrome, you need treatment for 6 plus 6, that is 12 weeks, that means 3 months. If there is a relapse, again the drug of choice is prednisolone. Relapse or infrequently relapsing nephrotic syndrome, the drug of choice is prednisolone. You give daily 2 mg per kg till remission, followed by alternate day for 4 weeks. If it is a frequently relapsing nephrotic syndrome or steroid dependent nephrotic syndrome, you can give low dose alternate day prednisolone, low dose alternate day prednisolone for long term, okay? So up to 18 months you can give. But if there are side effects of steroids that are happening, what will we have to do? We have to use steroid sparing agents like, so you can use levamisole or mycophenolate mofetil, okay, or cyclophosphamide, okay, cyclophosphamide. But if there is steroid resistant nephrotic syndrome, that means the child does not go into remission despite 2 milligram per kg per day steroids for 4 weeks. So the latest definition of steroid resistant nephrotic syndrome as per Nelson's textbook of pediatrics is the child does not go into remission despite 2 mg per kg per day for 4 weeks. Okay, prednisolone. So the drug of choice for steroid resistant nephrotic syndrome is calcineurin inhibitors. So calcineurin inhibitors, can you give me some examples? Like cyclosporin or tacrolimus. Cyclosporin or tacrolimus. And in refractory cases, you can even use rituximab, that is anti-CD20. Okay. For minimal change disease, usually all this is not required. Steroid resistant nephrotic syndrome, if it is there, then we will suspect non-minimal change disease like focal segmental glomerulonephrosis or membranous glomerulonephritis, okay, and so on, okay. So a 6-year-old child presents with hypertension, mild periorbital puffiness. He had sore throat 2 weeks back. Urine examination revealed hematuria and presence of RBC casts in urine. What is the diagnosis? So here you are having hypertension, some edema is there, history of sore throat 2 weeks back, hematuria is there, RBC casts in urine. So of course we are dealing with a child having nephritic syndrome, And the most common cause of nephritic syndrome in the age group of 5 to 12 years is post-streptococcal glomerulonephritis. Yes. So I can see all of you have answered correctly. So it is post-streptococcal glomerulonephritis. Okay. It is usually a self-limiting illness. So you have to do salt and water restriction, and you have to give antihypertensives for the hypertension, and usually the condition improves in 6 to 8 weeks. Okay. What condition is likely in an infant presenting with constipation? So, infant has constipation, umbilical hernia, dry rough skin, big tongue and rough hair. So, group A beta hemolytic streptococcus, okay, was there in the previous question, right. So, infant with constipation, umbilical hernia, dry rough skin and big tongue and rough hair, of course, we are dealing with a case of congenital hypothyroidism. Okay, congenital hypothyroidism. All these are features of congenital hypothyroidism. We can also call it cretinism. Okay. So, in Prader-Willi syndrome, what happens? So, Prader-Willi syndrome, there is obesity, hypotonia, hypogonadism, dysmorphism. So, these are some of the features of Prader-Willi syndrome, and Prader-Willi syndrome is a condition where there is genomic imprinting disorder is there. UBE3A gene is involved, chromosome 15, and there is a genomic imprinting disorder, or it can be caused by paternal deletion. Okay, paternal deletion can cause it. Edwards syndrome we know is trisomy 18, and galactosemia we have already discussed in detail, right? So, a little bit more about congenital hypothyroidism here. Usually, the most common screening test for screening, we use TSH, okay, TSH. So, we can either do it in the cord blood, umbilical cord blood, or heel prick. So, cord blood obviously we do it at birth, and heel prick if you have to do, you do it for at least 48 to 72 hours later to avoid the TSH surge, okay. And if the TSH is more than 20 milli-international units per liter, then we call it screen positive. And then you have to reconfirm it. You have to reconfirm it before labeling the child as having congenital hypothyroidism. If the TSH is still high, okay, in reconfirmation, then you must do a USG thyroid and a thyroid nuclear scan, thyroid scintigraphy or thyroid nuclear scan to look at the underlying cause. Because the most common cause of congenital hypothyroidism is thyroid dysgenesis. That means thyroid gland has not formed properly. But if a baby has goiter, the most common cause would be thyroid dyshormonogenesis. So, the most common cause of congenital hypothyroidism would be thyroid dysgenesis. But if goiter is present, then it will be thyroid dyshormonogenesis. Okay, and if we have found there is congenital hypothyroidism, we must give levothyroxine for treatment. And it is the most common preventable or treatable cause of intellectual disability in children, making it very, very important. Okay. Now, I can see some of you have already answered this question. Yes, a good job, Prem Kishore. So, a child has presented with a birth defect as shown in the image. You can see there is a defect of not only the cranium, but a large part of the spine as well. Right, cranium as well as a huge defect of the spine. So, this is a severe neural tube defect which is called craniorachis, which is not compatible with life. Anencephaly would be a condition where there is no spine defect, but you know the scalp, the cranial bones will be absent and brain will be seen from outside. So, this is not anencephaly. Myelomeningocele is a condition which is usually seen in the lumbosacral region, but it can be anywhere in the spine, and it is a sac of meninges which has, you know, some neural element also protruding inside. Okay. Aqueductal stenosis would present with hydrocephalus, enlargement of the lateral ventricles and the third ventricle, because we know aqueduct of Sylvius connects the third and the fourth ventricle. Okay. What can you do to prevent neural tube defects? So, to prevent neural tube defects, very important, to prevent neural tube defects in the baby, folic acid supplementation. Folic acid supplementation, okay, very, very important, has been asked previously. Even craniorachis has been asked previously, right? So to prevent neural tube defects in the baby, folic acid supplementation has to be done in the mother. The dose is also important, and when do you start is also important. Yes. So the dose will be 400 microgram per day in all women of childbearing age. Okay. And 4000 microgram per day or 4 milligram per day in high risk women, like those who have a history of previous baby with neural tube defect or those mothers who are on anti-epileptics. So in high risk women. Okay. And when is it to be started? So should we start it as soon as the pregnancy is diagnosed? No, that's a trap. So it should be started ideally. So to be started at least 1 month before conception. So before planning the pregnancy, you must start it. So at least 1 month before conception. And another important thing to be remembered is the neural tube defects have got multifactorial inheritance. That means host factors, genetic factors and environmental factors, all of them play a role. So it has got a multifactorial inheritance. Okay. Right. So a baby was born, so this obviously we've answered this question already. A baby was born with neural tube defect. What could have been given to the mother to prevent this condition? So we know folic acid could have been given to the mother to prevent this condition, right? What is the most common cause of seizure found in the age group of less than 5 years? Yes, is it febrile seizure, absence seizures, subtle seizures, myoclonic seizures? So I can see all of you answering correctly. Himanshu, Devil, Insha, Rahul, Kevna, Shivangi, Rashmi, Main Medicine, Priya Reddy, Akil, Vikas. Yes, so it is febrile seizures. So what do you mean by febrile seizures? So febrile seizures is a condition. So febrile seizures is not equal to just fever plus seizures. Okay. So febrile seizures refers to seizures in a child with significant fever. What do you mean by significant fever? Temperature of more than, so temperature greater than or equal to 100.4 degrees Fahrenheit. Okay. In a child, so in the age group of 6 months to 5 years without any evidence of CNS infection. Because if fever with seizures are present in a child, so it can be meningitis also. But if there is no meningitis, only then we call it febrile seizures. So without any evidence of CNS infection. Okay, CNS infection. The types of febrile seizures are simple febrile seizures and complex febrile seizures. Simple febrile seizures are usually generalized tonic-clonic seizures. Complex febrile seizures can be focal. Okay, can be focal. Simple febrile seizure lasts for less than 15 minutes. Complex febrile seizure can last 15 minutes or longer. Simple febrile seizure occurs only once during the episode of fever, and complex febrile seizures can be recurrent or frequent. So you can remember complex febrile seizure have 3 F's. What are they? Focal, 15 minutes and frequent. Okay, right? Now, what are the risk factors increasing the recurrence risk of febrile seizures? So, you know, febrile seizures, if happens in a child, it can be seen in recurrent episodes of fever. The risk factors which promote, increase the risk of recurrence of febrile seizures are age less than 1 year. If the seizure occurs when the fever has been there for less than 24 hours, if the seizure occurs at lower temperature, like when the temperature is between 38 to 39 degrees Celsius, then if the seizure is happening, then there are more chances of recurrence. Other risk factors are family history of febrile seizures, family history of epilepsy, complex febrile seizures, daycare, male gender, lower serum sodium at onset. So the most important risk factors are age less than 1 year, lesser duration of fever, lesser temperature. So lesser age, lesser duration of fever, lesser temperature at the onset of seizures. Okay. Now there are also some factors which increase the risk of epilepsy in these children. So factors increasing the risk of epilepsy in these children are complex febrile seizures, okay, focal seizures, family history of epilepsy, okay, and any neurodevelopmental abnormality in the child. What is the treatment of febrile seizure? Treatment of simple febrile seizure. Remember, no long-term anti-epileptics are required. You just make the child lie down in left lateral or recovery position. Okay. Do not give anything orally so that the child does not aspirate. If the seizure are lasting for more than 5 minutes, you can use either rectal diazepam, or nowadays you have midazolam nasal sprays available, you can use that. So, midazolam nasal spray can be used. Okay. No long-term anti-epileptics are required. No long-term anti-epileptics are required. Another important thing is, paracetamol. Giving paracetamol for fever, it does not decrease the risk of recurrence, does not decrease risk of recurrence of febrile seizures. It only makes the child more comfortable. Okay, right? A 4-year-old child was staring, he stopped blinking for 20 seconds, and which of the following drug would you advise for the treatment? So here what are we dealing with? So we are dealing with a case of absence seizures. Okay, absence seizures, the child was staring, stopped blinking, and he had, so this is absence seizure. Absence seizure is when brief episodes are there like daydreaming and there is no aura, no postictal phase, no unconsciousness. If you do a EEG, so absence seizure is precipitated by hyperventilation. Okay, and if you do a EEG, you will find a 3 Hz spike and wave pattern. Okay. So the drug of choice for absence seizure in children is valproate. In India, we give valproate, and in the West, ethosuximide is also used. Okay. Phenytoin is usually used, in a child with generalized tonic-clonic seizures, a child who presents with status epilepticus. The first drug to be given in a child with status epilepticus, of course, is lorazepam. Okay, first drug to abort seizures. What is recommended is IV lorazepam, which is a short-acting benzodiazepine. If that is not available, you can use either diazepam or midazolam. Okay. And I think the last question that we have for today. So, a 6-month-old infant. So, this is a 6-month-old infant with no neck control and social smile. So, there is developmental delay. No social smile at 6 months is definitely a red flag. So, a child with no neck control and social smile yet presents with sudden brief spasms involving flexion of neck, trunk and limbs occurring in clusters. EEG shows this pattern. So, this is a very chaotic pattern which is called Hips arrhythmia. Okay, it's called Hips arrhythmia. Very chaotic kind of EEG is there. EEG is electroencephalogram. Just like ECG is for heart, EEG is for the brain, electrical activity of the brain. So, this is Hips arrhythmia on EEG, and what is the drug of choice. So, I can see you all answering. So, very good to see your enthusiasm going on till the very end. So, yes, it is a case of West syndrome. We diagnose it with a triad. What is that triad? So, there is global developmental delay, okay, infantile spasms. So, these infantile spasms are also called salam attacks. Okay, why are salam attacks? So, what happens is, look here. So, what happens is the child will have like this. So, these are infantile spasms or flexor spasms or salam attacks. Okay, and what else? There is this Hips arrhythmia on EEG. Hips arrhythmia on EEG. So, this triad of findings, if you are getting, we diagnose it as West syndrome. And the drug of choice for West syndrome is injection ACTH or adrenocorticotropic hormone. If that is not available, we can use corticosteroids. While drug of choice for infantile spasms in a child with tuberous sclerosis is vigabatrin. Okay, vigabatrin, right? So going back to our question, so of course this is a child with West syndrome and our drug of choice then becomes ACTH. Valproate we have seen is the drug of choice for, so for absence seizures and for juvenile myoclonic epilepsy, the drug of choice is valproate. Ethosuximide is again used for absence seizures mainly in the West. In India, we mainly use valproate for this. Carbamazepine or oxcarbazepine is usually used for focal seizures and used in disorders like benign epilepsy with centrotemporal spikes or Rolandic epilepsy. So, carbamazepine is mainly useful for focal seizures. Okay, right? So, I think that is all for today. So, all the very best for your upcoming exams. Keep this momentum going on. So, the last few days to go. Keep working hard, revise your content, whatever you've studied till now. Try to do at least 2 more revisions starting from now. And of course, I'm sure all of you who have the dedication to, go through sessions like this and to consistently keep studying, keep answering, keep inspiring each other. And, don't worry about the result because, the best way to predict your future is to create it, right? Rather than worrying, work hard in the direction that leads you to the success in this exam. So this FMGE exam, we all know there is no negative marking. So try to attempt all the questions. Read the question very, very carefully. Read all the 4 options before answering it. I'm sure you must have benefited from this session. So if there are any further queries and any other things that you want to ask me, you are free. So cerebral palsy, okay, cerebral palsy is a static encephalopathy, okay. So cerebral palsy is a condition which is due to one-time insult to the brain. So what happens, suppose a baby was born and the baby did not cry immediately after birth. So there is some hypoxic insult or injury that is happening to the brain. Now because of that, the baby can have neurological sequelae that is called cerebral palsy. So cerebral palsy is a static encephalopathy. That means it is due to one-time insult. So the baby will have developmental delay, the baby may have spasticity of the limbs, but slowly if you give extra care, the baby will gain milestones. So it can present with spastic quadriplegia in term babies. In preterm babies, it is usually spastic diplegia due to involvement of periventricular areas. Vitamin D resistant rickets, somebody is asking. So vitamin D resistant rickets, what happens? So here it is a condition, especially VDDR type 2. What happens? There is problem at the level of receptors. Vitamin D is present adequately, but the receptors are insensitive. Vitamin D is not able to act. So it is a very difficult to treat situation. You have to use calcitriol or active form of vitamin D for treatment and high doses of calcium. Even calcitriol doesn't act. So in VDDR type 1, you can use calcitriol. In VDDR type 2, where end organ resistance is there, even that will not work properly. High doses of calcium may be required for treatment. Okay. Yes, any other queries? PDF you will get it. Sure, by the end of the day you will get the PDF. So a little bit about APGAR score. So APGAR score is a score which has 5 components. A is for appearance, P is for pulse rate, G is for grimace, another A is for activity, and R is for respiratory effort. So these are the 5 components. Each of them can be given a score of 0, 1 or 2. So remember, APGAR score has no role in neonatal resuscitation. Okay, it only helps in giving the prognosis or the outcome of the child. So APGAR score more than 7 is taken as normal. 4 to 6 is a moderately depressed baby. 0 to 3 APGAR score is a severely depressed baby. It indicates severe birth asphyxia. Yes? Or any other queries? So I think you have answered most of your questions. So Hirschsprung disease, somebody is asking me. So Hirschsprung disease is due to problem in the descent of neural crest cells. They are not reaching the rectum and anal canal. So there is failure of relaxation, normal relaxation of the bowel loops. So the child can present with delayed passage of meconium or intestinal obstruction or toxic enterocolitis, right? And you can see on intestinal biopsy, you can see hypertrophic nerve bundles and so on, right? Yes, it is called aganglionic megacolon, right? So please continue to revise, right? You can go through this session once again, you can go through the PDF, also try to go through again the rapid revision videos and the PYQs. Any PYQ that is coming, make sure you do not make any mistake on it. So you have studied well till now, keep that momentum going. If you have any queries, you feel free to message it to me. So all the very best, God bless you. I hope you're going to do very well in your upcoming exams. Hoping to hear from each and every one of you who have watched this session, hoping to hear your results, and I'm sure you'll make it to the other end and very successfully. Thank you so much.